everything is perfectly aligned to start our next session, which is general surgery, and it will be taken by a wonderful faculty, Dr. Gaurav Patel. Well, it is mentioned somewhere in our epic text that every professional, whenever he takes a decision, it's based on three things: knowledge, intuition, and experience. And we all know experience comes by age, intuition is a gift, and knowledge is something we can consolidate upon. And for that reason, we are here more than happy to assist you people to acquire knowledge to make you wonderful professionals and achieve your academic goals. I give you here a brief of our next esteemed speaker, Dr. Gaurav Patel. Dr. Gaurav Patel has done his MBBS from KMC Mangalore. He's done his MS surgery from PGIMER and Dr. RML Hospital, New Delhi. He's done his DNB surgery. He's got fellowships in minimal invasive surgery, colorectal surgery, hepatobiliary surgery, and hernia surgery. He has a vast experience of 12 years in teaching and training postgraduates in surgery. He cherishes every moment being with DAMC medicos and communicating and connecting with you wonderful people. Without taking much time, I welcome formally Dr. Gaurav Patel, who will be taking general surgery now. Over to you, sir.
Hi, good afternoon. Am I audible? Am I audible? Good afternoon, all of you. So today is the last day of the DVT, and I'm sure it must be a beautiful journey for the last 7 days, including today. Okay, all the subjects covered in a crisp, concise manner, a quick revision. Okay, so good afternoon, all of you. And when I say revision, keep focus on the word revision. Okay, like I saw in the last session, see, this is not the first time you are reading these things. Maybe you cannot recall at this time, that is a different thing. But we have already covered all these things. There is nothing new in these sessions. Okay, so maybe if you open up your books, open up your notes, you will see that all of these things have been covered in the class notes. It has been asked and discussed in the tests, GTs and all these things. Okay, so it is a revision. Consider it as revision only. Okay, so like most of you are saying, you are asking questions and all, but this is a DVT session, a quick revision. You cannot do the surgery, the whole surgery in 5-6 hours. So this is a revision. We'll take it as revision only. Okay, so let's start. These are the things I'll be covering: general surgery part, trauma, hepatobiliary, pancreatic system. Okay, so we'll start with the trauma part. Okay, so trauma, the first thing, see, triage. Triage, the basic meaning of word triage is to sort out. To sort out the patients in mass casualty. Okay, so you have to do this sorting out based on the salvageability. The most important thing is salvageability, ability to survive. Okay, suppose you go as a triage team leader somewhere to do the triage. You have to save as many people as possible. Your goal is not to save those people who are very severely injured. Your goal is to save as many people as possible. So the team leader, when they go there, they do this color coding in the triage. Red is the immediate, like some airway obstruction, massive bleeding, tension pneumothorax. Okay, yellow is urgent. Urgent means these people, they need hospitalization, but they can wait for some time. There is no immediate threat to life. Green is ambulatory. And black are those people who are already dead, or the injuries are so severe that no matter what you do, they are going to die. Okay, so in this black, we'll say we'll do expectant management. Expectant management means you will not waste your resources, your manpower on these people, because no matter what you do, they are not going to survive. Okay, so if we see the priority, red is the first priority, then comes yellow, then comes green, and black is the last priority. Yes, moribund or dead. Okay, so now suppose the trauma patient comes to the casualty and you want to treat that patient. You have to follow the ATLS guideline, Advanced Trauma Life Support. Primary survey is your initial contact with the patient. No, there is no specific time as such for yellow. Okay, means after you finish with the red, you can take care of the yellow patients. Okay, you have to follow the order: airway, breathing, circulation, disability is neurological status, and E stands for exposure and environmental control. Okay, and remember, cervical spine stabilization comes first. Okay, first you will do the spine stabilization. Then you'll go for A, B, C, D, E. So remember this thing, if they ask like which is the topmost priority, spine stabilization is in the option. This is the topmost priority. Okay. Adjunct to primary survey. Adjunct to primary survey. See, this is some investigation, certain blood investigations like coagulation profile, blood grouping, okay, chest X-ray, pelvis X-ray. You will put the Ryle's tube, Foley's catheter, ECG, pulse oximetry. These are the things you will do in adjunct to primary survey. And remember, if there is CSF coming from the nose, don't put Ryle's tube through the nose. While putting the Foley's catheter, if you see that there is blood at the tip of the external meatus, don't put Foley's catheter. That means there is suspected urethral injury, and we don't put Foley's catheter in trauma if there is suspected urethral injury. Okay, secondary survey is when you will take the history and detailed head-to-toe examination. Head-to-toe examination. And adjunct to secondary survey is nothing. This is just when you are like, if some other investigation, or you want to send the patient for, you want to transfer the patient to some other facility, that is adjunct to secondary survey. Now one thing you remember, that suppose they ask this FAST, I hope you know what is FAST, focus assessment sonography in trauma. FAST comes in out of these four where? So FAST is a part of adjunct to primary survey. Okay, so FAST is a part of adjunct to primary survey. In case they ask this question, that where does the FAST stands in ATLS, it is adjunct to primary survey. Yes, ample history, very good. Now Glasgow Coma Scale. Glasgow Coma Scale or GCS, this is one of the most important scoring system in the trauma. And I'm sure you know the things. What are the three things we see? The eye opening, the verbal response, and the motor response. And the most important is the motor response. Most important is the motor response. CT scan is not the part of the primary and adjunct to primary. If you say a CT scan or some other CT, that will go in adjunct to secondary survey. Okay, so 4, 3, 2, 1. Eye opening spontaneous, to voice, to pain or pressure, and none. Verbal response 5, 4, 3, 2, 1. Patient is oriented, confused. If the patient is speaking in words instead of sentences, if the patient is speaking in words, if the patient is producing sounds, and if there is no verbal response, 1. And motor 6, 5, 4, 3, 2, 1. I'll tell you where people they do mistake in this. 6 is when the patient obeys command. 5 is when the patient can localize the pain. 4 is when there is withdrawal to pain. 3 is abnormal flexion. 2 is abnormal extension, and 1 is no motor response. Okay, so where does they do the mistake? See, suppose you pinch somebody and the other hand will come and they'll try to push you away. That is localizing the pain. Suppose you are giving some pain, some pressure, and the patient withdraws the hand like this. Okay, this is the withdrawal. So what is this movement? This is flexion. So in the question, if it is written there is normal, or they write there is flexion response to pain, then it is 4. Okay, so you can say withdrawal is same as normal flexion. Normal flexion. Suppose you give the painful response and the upper body goes like this. Okay, the whole body goes like this flexion. That is abnormal flexion. And if the body goes like this, the hands, the arms, then it is abnormal extension. Okay, so remember flexion response to pain. If they write, you have to give 4 points in the motor response. Okay, so and if the GCS is less than or equal to 8, this is the time when you have to intubate the patient, put the endotracheal tube. Okay, so if you put the endotracheal tube, now the patient has come to you, you try to see the verbal response, the patient will not be able to speak because the tube is going between the vocal cords. So you will write VNT, non-testable. Okay, so in all these things, there you should add one more thing, non-testable, non-testable, and non-testable. Non-testable. Okay, yes, very good, non-testable. Moaning will be sounds. But if the patient is gasping, gasping is no verbal response. Moaning is sound, but gasping is no verbal response. Okay, so GCS, very, very important scoring system. Coming to the next picture, okay, I have put more of the images. So this is kind of an image-based discussion, most of the things. So you don't have to write much. I mean, you have to write maybe a little bit more than what was the last session, Tiwari session. There was everything was written. Here you might have to write a little bit. Okay, so this is the picture where you can see this is the normal heart and this is the pericardium which has been opened. So in this condition, there is some injury in the heart and the blood has entered in the pericardial space. So this condition is cardiac tamponade. Cardiac tamponade. The main problem in the cardiac tamponade is now this blood which has accumulated in the pericardial space, it will not allow the venous return to come back. So that's why this is an example of obstructive shock. Obstructive shock. Okay, so this is a type of obstructive shock. Remember, don't mark it as cardiogenic shock. Cardiogenic shock is when the heart is not able to pump blood. In this case, the heart is not getting the blood. If you give the blood to heart, heart will pump. There is no problem in the pumping mechanism. Okay, so that's why it is an obstructive shock. Yes, you will see backstride. Okay, this is the mnemonic I tell. MDH is the mnemonic, muffled heart sounds, distended neck veins and hypotension. Backstride, muffled heart sounds, distended neck veins and hypotension. There will be tachycardia also, but this is the triad. Okay, so although fast image will not be given to you, but suppose this is the heart and this one is the pericardium. This is the fluid which is accumulated or the blood which is accumulated in the pericardial cavity. So investigation is fast. Remember, it is fast, not extended fast. It is a normal fast which will detect the cardiac tamponade. Management is, this is an emergency condition. You will put a needle and aspirate the blood, pericardiocentesis. So pericardiocentesis is the management, initial management. After that, when the patient becomes a bit stable, you can take the patient to the OT, open up the thorax and see the injury in heart and repair that injury in heart. Okay, echo-guided, not echo-guided, it is ultrasound guided basically. Okay, Sakshi, ultrasound guided in, see, fast and these things are done by the surgeons. These patients will come to the casualty in the surgery. You will not find cardiologist sitting in the surgery casualty. Okay, so from where will you, I mean, you will call the cardiologist, they will come with the echo and then, so this is a simple ultrasound guided, put the needle. Oh, the echo is not required. Okay, so next condition, see this, when there is blood in the pleural cavity, this is hemothorax. Hemothorax. So because of this bleeding, see this blood, we are not worried about bleeding as such in hemothorax. Most of the bleeding, 95% of the bleeding will stop spontaneously. What we want is, we want that fluid or the blood to come out so that the lung will get a space to expand. Okay, so that's why in hemothorax, see, this is the X-ray showing obliterated the right-sided costophrenic angle. This is the accumulation of the fluid. But these days we do the investigation with the E-fast. Okay, so yes, investigation we'll do is E-fast. And then after confirming that it is hemothorax, you put a ICD, intercostal chest drainage tube, ICD. Now, two things about ICD. The size of ICD which we are supposed to put in hemothorax is 28 to 32 French. The site is usually 4th or 5th intercostal space just anterior to the mid-axillary line. Okay, so this is the site. But suppose this is not in the option and this is the proper exact site. But a safe area is there where you can put the ICD. This is known as triangle of safety. Okay, triangle of safety is latissimus dorsi anterior border at the level of the nipple horizontal line, and this is pectoralis major, the lateral border. So that is triangle of safety. That is a safe area. Our 5th intercostal space mid-axillary line will fall in this triangle of safety only. Okay, so majority of the cases will treat by putting this ICD, but yes, the question is now, very important question, what is the indication for surgery? Indication for surgery, because ICD is just a procedure. It is a bedside procedure. When will you do surgery? Surgery means thoracotomy, when you have to open up the thorax. Okay, so indication for surgery, two important indication. See, the moment you make the diagnosis, it is hemothorax, you put the ICD. After putting the ICD, suppose more than 1500 ml blood comes immediately. More than 1500 ml blood from ICD immediately. That is one indication. Another indication is, suppose it's not more than 1500, suppose it is 600, 700, then you will see every hour how much blood is coming out. And if it is more than 200 ml every hour for 2 to 4 consecutive hours. So these are the two main indications for doing thoracotomy in case of hemothorax. Yes, very good. All of you, I'm like very proud to see you people answering the correct things which was taught in the class. Okay, so this is like a very great feeling for a teacher, that when your students, they remember the thing, they recall the thing. Okay, and this, all you have to do in the exam also, just recall these things, and you will be like, in surgery you will score like, suppose there are 30 questions, I am sure you will mark more than 25 questions correct. Okay, so this is about hemothorax. The next picture, you can see this picture. Can you tell me what is this? This is flail chest. Now, two important things in flail chest. The first thing about flail chest is the definition. The definition. Okay, so definition of flail chest. If there is fracture of 2 or more consecutive ribs. Fracture of 2 or more. Now in few books it is written 3. 2 or more consecutive ribs. And at least 2 fracture in each rib. At least the rib should be fractured at least 2 sides. Okay, so this is flail chest. So very important in flail chest, there is this paradoxical movement. That segment which has been fractured, that gets separated from the rest of the thoracic cage, and you will see paradoxical movement of that segment. Now because of this paradoxical movement, at the time of inspiration, when the lungs are expanding, the rest of the thoracic cage is also coming out, this flail segment will go in because of this paradoxical movement, and it will hit the expanding lung, leading to pulmonary contusion and leading to the main problem of the patient. Okay, so pulmonary contusion is the main problem. Now treatment. Now remember, whenever they will give question of treatment on flail chest, they will always tell you whether there is respiratory distress or no respiratory distress. So if there is respiratory distress, the treatment is you need to put an endotracheal tube and put the patient on intermittent positive pressure ventilation. And if there is no respiratory distress, then all you have to do is oxygen by mask and give some analgesic. There are so many ribs are fractured, so analgesics are required. Strapping, any kind of strapping, wiring, surgeries, these are not done for flail chest. Okay. Yes, very good. Next condition. See, there is air which is going into the pleural cavity. So this condition is pneumothorax. Pneumothorax. Okay, clinically, how will you differentiate hemothorax from pneumothorax? In hemothorax, on percussion, there will be dull note. In pneumothorax, there will be hyperresonant or tympanic note. Okay, clinically, you can differentiate. In both the cases, there will be decreased chest movement, there will be decreased chest rise, there will be decreased breath sounds. But yes, this clinical percussion will help you differentiate whether it is pneumo or hemo. Okay, so pneumothorax. Now in pneumothorax, see, although the x-rays, these days we don't do x-rays in pneumothorax, we do e-fast only. But still on x-ray, you can see this is the normal lung. Normally lung is slight grayish and there is bronchovascular marking. In this picture you can see this whole thing is air. And this air has compressed this lung. This is the boundary of the lung. So the lung has been, compressed and it is not getting the space to expand. So this is the x-ray. But yes, investigation, e-fast. On e-fast, see, this seashore sign is a normal sign. Normal sign. Okay, so if you can see this image, how will you identify? See, this dot 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 like appearance, it looks like a beach. So consider it as beach and consider these as ocean waves. Okay, these are the ocean waves. Now what happens in the pneumothorax? Pneumothorax, there is something known as barcode sign or stratosphere sign. So just imagine pneumothorax is a severe condition. So like the tsunami comes, which is a very severe thing. Just consider that in the patient body there is this tsunami and that's why the whole ocean has come on the beach. So that beach is washed away. There's only ocean, only these waves are there. So that is barcode or stratosphere sign. Okay, so that is e-fast. Now the treatment of pneumothorax, you need to understand when we talk about the treatment, there are three types of pneumothorax. One is a simple or closed type. Simple or closed type, see what happens in these cases. Suppose the air is coming from the lung and accumulating in the pleural cavity. Okay, some amount of air is going back also. So that's why there is bidirectional flow of air into the pleural cavity. The patient is not very sick. So that's why in these cases in the treatment, either you can observe, wait and watch, or you can put a ICD. Now whenever you are putting ICD, ICD goes at that place only, fifth intercostal space, anterior to, just anterior to mid-axillary line or mid-axillary line. Okay, so either you observe or you can put the ICD. If there is respiratory distress, you put the ICD. So it is not that dangerous. Open pneumothorax. In the open pneumothorax, there is a open defect on the chest wall. There is a hole in the chest wall, like suppose somebody was shot by a shotgun or there is some penetrating injury. So because of this open defect, if this defect is more than 2.5 centimeter, then what happens? See, normally in the lung, when we do the breathing, the lungs expand because of the negative pressure. Now because of this 2.5 centimeter or bigger defect, now the outside pressure and the inside pressure becomes same. So same means there is loss of negative pressure. So when there is loss of negative pressure, this lung will not expand. Okay, it will fail to expand because lung needs negative pressure and there is loss of negative pressure. So it will fail to expand. So that's why, yes, very good, Devrati, we'll do three-sided occlusive dressing. Okay, so in the treatment, three-sided occlusive dressing. followed by ICD. So ICD you need to put in this case also, but the first thing you have to do is 3-sided occlusive dressing. And when you're putting ICD, don't think that, okay, there is such a big defect and let me put ICD through this. Okay, you have to put the ICD from a different area, not from that injured part. Okay, so this is open pneumothorax. Third type, which is most dangerous, it is tension. In the tension pneumothorax, there is only one-way flow of air into the pleural cavity. Okay, suppose air is going into the pleura, it is going into the pleura only, it is not going back. Okay, so there is one-way flow of air. Yes, flap valve type of mechanism. So that's why in these cases, the things will occur at a very rapid rate. Okay, so the patient will be like, the symptoms will be very dramatic. Very soon the patient will have severe respiratory distress. And now because of rapid accumulation of air, it will rotate the heart to the other side. So when the heart rotates, again the venous return decreases, and that's why this is also example of obstructive shock. This is also obstructive shock, and because of decreased venous return, there will be hypotension. Okay, so in the exam, how will you know they are talking about a simple or tension pneumothorax? Remember, tension may you will see hypotension. Okay, so if there is hypotension written, then only you will say it is tension pneumothorax. Okay, so the treatment is initial treatment. You will put a needle, and after you put the needle, you will put the ICD also. So initial treatment is needle. Needle in the adults, the site is same as ICD, 5th intercostal space, mid-axillary line. In children, it is different. It is 2nd intercostal space, mid-clavicular line. Okay, so these are the 3 types of pneumothorax and the treatment of these 3 types of pneumothorax. Okay, next picture, the next thing. You can see there is diaphragmatic injury. So in the diaphragm injury, just again 2-3 important things. It is more common on the left side as compared to right. Okay, usually they don't have any immediate like aggressive symptoms, so that's why many times the disease goes or the condition goes unnoticed in the beginning. Maybe the patient will come after 15 days, 20 days with some chest pain, some respiratory distress. So that's why delay in the diagnosis is common in these cases. Second thing, no ICD. Don't put any ICD because the content is in the thoracic cage, the gastric content, abdominal content. So that might get injured if you put the tube. And the only treatment is surgery. You have to do the surgical repair. You can do the primary suturing of the diaphragm, or you can put a mesh also. Okay, and suppose they ask what is the best investigation, then it is diagnostic laparoscopy. Diagnostic laparoscopy. Needle used in the tension pneumothorax, usually it is a 14 gauge needle, at least 8 centimeter in length, and over the sheath. Over the sheath means like IV cannula. ICD, whenever you put ICD, water seal has to be there. ICD, one end is in the thoracic cage, the other end should always be in a underwater, you know, there's, you put 100 ml of saline there. Okay, it cannot directly open into the air. Okay, so it has to be a water seal. ICD is always with a water seal. Okay, next is, see, if the patient comes with blunt trauma abdomen. Blunt trauma abdomen, investigation of choice, if the patient is unstable. Now, what is unstable? Unstable means when there is tachycardia, when there is hypotension. Investigation of choice is FAST. Focused assessment sonography in trauma. Okay, so this FAST is usually done by the surgeons. They will put the ultrasound probe at these areas. The sequence is usually, first is the epigastric, then the second is right hypochondrium, left hypochondrium, and fourth is pelvis. This you are putting to see the cardiac tamponade. The other 2, 3, and 4 you are checking the free fluid in the abdominal cavity. Okay, so the FAST does not tell you that the injury is in the kidney or the liver or the spleen. The FAST will only tell you that whether any free fluid is present in the abdominal cavity or not. If it is present, it is fast positive. If it is absent, it is fast negative. So there are just two reports of fast, either positive or negative. Okay, so then they ask question, how much minimum free fluid should be there to be detected by fast? 100 ml. 100 ml. So this is fast, which is now the ultrasound machines are quite widely available. So that's why they thought that if it is such a good investigation, why don't we put the probe at the thorax, and we can see the thorax also like hemo and pneumothorax. So when you start looking the thoracic cavity, it becomes E-fast, extended fast. So that is extended in the E-fast. You start looking the thoracic cage also. Okay, so unstable patient, the investigation of choice is fast. Okay, suppose the patient is stable, hemodynamically stable, and they ask what is the investigation of choice. Investigation of choice is CECT, contrast enhanced CT of the abdomen. But suppose they ask what is the next investigation, then it is fast here also. Okay, so fast is the next investigation, but the better investigation in a stable patient is CCT because the patient is stable. You can, CCT is always a better investigation to look for the trauma, but in unstable patient there was some ongoing bleed and the patient did not have time for this CT scan, which is a obviously lengthy investigation. It takes 1.5 hours for a CT scan to done, and that patient was not stable enough for a long duration investigation, so that's why we did fast. Otherwise CCT. Okay, so on CCT you can see different images. What can you see? Suppose if I say this is image A, this is image B, this is image C. Quickly tell me, looking at the CT, what can you see in this image A, B and C? How to do open patient clinically? Syed, I don't know, DX is diagnose open patient clinically. I mean, seriously, I'm not able to understand your question. Okay, so yes, this is a splenic trauma. You can see this is a splenic injury. Splenic injury. This is a liver injury. And this one is a kidney injury. Okay, now one thing I want to tell you, in this case, see one image, this CT. So can you see this arrow is showing that this contrast, CCT is contrast enhanced CT. Sometimes the patient is stable, but there is an area from where the contrast is leaking. So that is known as contrast extravasation. Contrast extravasation. So contrast extravasation means that although the patient is stable, but there is an area which is bleeding. Now that bleeding is not significant, so that's why the patient is stable, but there is an area which is bleeding. So they ask what should be the treatment. So if there is contrast extravasation, the treatment, remember, it is angioembolization. Angioembolization. Yes, contrast blush or contrast extravasation. Angioembolization. You are not supposed to do surgery because the patient is stable. Angioembolization is good enough. Okay, liver trauma, I'll tell you very basic thing. Okay, this is what I tell in the class also. Suppose there is a patient, just listen to this. Suppose there is a patient, how to diagnose open pneumothorax clinically? There will be an open wound there. Okay, and the patient will have the features of pneumothorax. There will be hyperresonant note and the lungs are not expanded. So that is clinically means there is a, suppose the patient comes and with a bullet wound in the abdomen. Okay, so the patient will tell you that, okay, somebody shot me with a bullet. So you don't have to do any special investigation to say that it is bullet wound. Patient is telling you, you can see that there is a bullet going there. So similarly, patient will say that there is a open wound here. The patient is having problem in the breathing. So obviously it is pneumothorax only. Okay, it cannot be hemothorax because if there is blood flow, it will come out. So it is air and the lungs are not expanding. So it is not difficult to diagnose. Okay, liver trauma. So see, in any case of abdominal trauma, suppose the patient is unstable. So when the patient comes to you, you do the fast. Fast tells you that it is positive because there is free fluid. You take the patient to the surgery, you open up the abdomen, When you open up, there will be lots of blood. So first you do 4-quadrant abdominal packing. After that, you remove the packs one by one. Suppose you have localized that the site of injury is liver. Okay, so when you remove the pack from the liver, you will see that, suppose this is the area, it is bleeding. So first you try to give some pressure. Okay, so that is known as push. If there is a penetrating type of injury, then you can put a catheter and try to give pressure by inflating that balloon. So that is plug. Suppose that also fails to stop the bleeding, then you can do Pringles maneuver. Now Pringles, they ask question image-based type. This is the Pringles maneuver. You do the occlusion of the inflow. Okay, you will put the clamp on the hepatoduodenal ligament that contains hepatic artery, portal vein, and the bile duct. And suppose that also fails to control, then see, by this time the patient has already bled enough. This is the time when the patient is going to die on the table, on the OT table. And nobody wants that the patient, I mean both anesthesia as well as the surgeon, they don't want that the patient dies on table. So you have tried to do these things. You don't have an option to remove the liver because nobody can live without liver. So as the last resort, you will put lots of packs around the liver. So that is perihepatic packing. Perihepatic packing. So these are 4 P's in the management of liver trauma. This is all you can do to save the patient's life. Later on, if the patient survives, you can remove the pack in the second surgery. Okay, so this is the Pringles maneuver is an important exam question. Now suppose a patient with massive abdominal trauma comes. So by the time patient comes, the patient is having acidosis, hypothermia, and coagulopathy. Okay, acidosis, hypothermia, and coagulopathy. Acidosis means suppose pH is less than 7.2. Hypothermia is temperature less than 35. And coagulopathy means PT more than 16 seconds or PTT more than 60 seconds. So this patient has come and there is massive abdominal trauma. Now, after opening up the patient, when you will see that the extent of the injury is massive and you cannot do or repair all these injuries in the next maybe 60 to 90 minutes, then instead of doing all the things in one go, you can change your surgery to a damage control surgery. Okay, so this is damage control surgery. Phase 0 is the pre-hospital thing. Pre-hospital, before the patient reaches the hospital, you have to follow certain things. You don't give too much of crystalloid, limit crystalloid. These days they say that you give 1 liter bolus. As soon as the blood is available, start blood transfusion early. Third thing, don't try to maintain the normal blood pressure. You have to maintain the blood pressure a little bit less than normal. So that is hypotensive resuscitation. What should be your goal of systolic blood pressure in this? If not normal, if it is not 120, then what should be the goal of systolic blood pressure? Goal of systolic blood pressure is 90. If it is 90, you are happy because at 90 your vital organs are getting the blood supply and the area which has stopped bleeding, it will not rebleed. So that's why we try to maintain less than normal VP. Goal mean arterial pressure should be around 60. Not more than 60, not more than 90. You're happy. Okay, and the fourth thing is injection tranexamic acid. That is the only drug which has a life-saving role in the trauma. So this is what you do in the phase 0 pre-hospital. Then phase 1, the patient reaches hospital, you will do a abbreviated laparotomy. Abbreviated laparotomy means you will do the surgery, and in this surgery, the surgery you have to do for the minimum required period, 30 to 45 minutes. If there is any bleeding, control the bleeding. If there is any like perforation, you just have to close that perforation. You don't have to do definitive repair. Control bleeding, limit contamination. If required, pack the abdomen and leave the abdomen open, or you can do some temporary closure. Phase 2, send the patient to ICU for 48 to 72 hours maximum. So the ICU people, they will treat this acidosis, coagulopathy, hypothermia, and now the patient is better. So you can do the second surgery, that is the definitive surgery. That should be done in 48 to 72 hours. And this time, if it is possible to close the abdomen, you close the abdomen. Otherwise, you can do the abdominal closure later after 5 to 7 days. So that will be phase 4, abdominal wall closure. So phase 4 may or may not be there depending on in phase 3. If you have closed the abdomen, then there is no phase 4. But suppose in phase 3, if the abdomen is still open, then you can close the abdomen later on in phase 4. Okay, so this is damage control surgery. I can see the chat. All of you are, absolutely, marvelous. You know the things. You know what we are supposed to do. This is, a very proud moment for me. Okay. This condition, self-explanatory. No need to tell. This is a seat belt injury. Seat belt injury. BT is blood transfusion, Ria. And remember, in blood transfusion, one more thing I used to tell in the class, that if you know the blood group of the patient, you give cross-match blood. But if you don't know the blood group of patient and you have to give some blood group, if that patient is a male, give O positive. If the patient is female, give O negative. Okay, in case if you don't know the blood group, O positive for male, O negative for females. Okay, the most common site which is injured is mesentery. Mesentery is the most common organ which gets injured in the seat belt injury. Triad has to be corrected. See, it's not one phase in which you are correcting the triad. If you send the patient directly to the ICU, then also the triad will not be corrected because the main problem is bleeding. So until unless you control that bleeding or you control that contamination, no matter what ICU people will do, it is not going to get corrected. Okay, so triad correction has started in your surgery only, but it will be completed in phase 2 in ICU. Okay, so but both the things are dependent on each other. Okay, only ICU is also not enough and only surgery is also not enough. Okay, see, this is the zones of retroperitoneal hematoma. Zones in retroperitoneal hematoma. Okay, so retroperitoneal hematoma, you can see zone 1 is in the center. So if there is any injury in the aorta or IVC, that will form hematoma in zone 1. Zone 2 is the flank area. If there is any problem in the kidney or the renal vessel, that will cause hematoma in zone 2. And zone 3 is in the pelvic area. In case of iliac vessel injury, it will cause hematoma in zone 3. Now suppose the mechanism of injury is blunt or penetrating. So what should be the treatment in zone 1, 2 and 3? If it is penetrating, you have to do surgery no matter what zone it is. In case of blunt, zone 1 surgery. Zone 2 non-operative management or conservative. Zone 3 also non-operative management or conservative. So in zone 2, if there is blunt trauma, mainly the treatment is non-operative. If there is active bleeding, then only you have to do surgery. Okay, so I'll write surgery if active bleed. And in zone 3, if active bleed is there, you go for angioembolization. Angioembolization. Okay, so this is the management. This one table is very important. They ask questions on this. When to do surgery, when not to do surgery. Okay, here you will do surgery except retrohepatic IVC hematoma. Now there cannot be any question outside this in the management of retroperitoneal hematoma. NOM is non-operative management. That is the standard abbreviation. See, if I'm using any abbreviation, that is the standard abbreviation. They might give in the option in the exam also. Conservative, non-operative is the same thing. Okay, zone 1 is the central, where there is aorta and IVC, central zone. Zone 2 is laterally in the flanks, and zone 3 is the pelvic area. Okay, non-operative management is conservative management. In the head injury, I am sure in the radiology also this must be discussed. This is the biconvex shape hyperdense lesion is EDH. EDH does not cross the suture line, that's why this appearance is given. And the cause of EDH, the source of bleeding is middle meningeal artery. Middle meningeal artery is the source of bleeding. Another image showing a concavo-convex opacity, that is SDH. And the source of bleeding is bridging veins. Among EDH and SDH, in which case lucid interval is more common? Okay, more commonly lucid interval is seen in EDH. Lucid interval is more common in EDH as compared to SDH. Okay, although it can be seen in SDH also. Suppose there is a question, lucid interval is seen in option number A EDH, B SDH, C both EDH and SDH. Then C, that is both, will be the answer. But suppose you have to choose one among EDH and SDH, it is more commonly seen in EDH, so EDH will be the answer. Okay, so when you do the management of a head trauma patient, remember in head trauma patients will have hypertension, bradycardia and irregular respiration, that is the Cushing's triad. So this kind of question they are asking these days very commonly, what is the cause of hypotension in a head trauma patient? Hypotension in a head trauma patient is mostly because of some intra-abdominal or thoracic injury which is associated with head injury. Because if the patient is having only head injury, it will cause hypertension, not hypotension. Okay. If the patient of head trauma comes, you do the treatment, whatever conservative, non-operative or conservative, or even if you do surgery, how nicely or how badly the patient has recovered, that is given by Glasgow outcome score. Good recovery. Just suppose we'll take example, suppose the patient was mechanic before and now there was some head injury, you have done the treatment, the patient has recovered, he went back home. Now if he's able to do what he was doing before, like if he's able to do his mechanical work, then it is good recovery. You will say 5. Moderate disability 4. Moderate disability means patient is not able to do mechanic work, but he can take care of himself. Patient is independent. Independent, he can eat on his own, he can go to the washroom, patient is independent. Severe disability 3. Patient is dependent on someone for his day-to-day work. Okay, he needs somebody to take him to the washroom, somebody to feed him. Persistent vegetative state is coma, and if the patient dies, it is 1. Okay, so this is Glasgow outcome score. You can see the prognosis or how the patient has recovered after head injury. Next is, this is, I'm sure all of you know, this is Lee-Ford's classification. Indication for craniotomy at your level, just remember 2 important things. If the patient's GCS is less than 8, if there is midline shift more than 5 mm, or if there is focal neurological deficit. Focal neurological deficit means there is some pupillary dilatation, some hemiparesis. Okay, that is one thing. Midline shift more than 5 mm and GCS less than 8. Okay, other things they will not ask in your exam, that is kind of super specialty exam. They will ask about the thickness of the hematoma, volume of the hematoma. So just remember 2-3 things. Lee-Ford's classification of midfacial fracture. Lee-Ford's one is horizontal. Okay, so you'll see in this case there will be eyes and the CSF rhinorrhea will not be seen. Only there will be there is some edema around the lip. That is the main problem. 2 is pyramidal. You can see the fracture line goes like this, so it looks like a pyramid, pyramidal. And 3 is transverse. Transverse, or you can say that there is craniofacial dissociation because the skull bone gets separated from the facial skeleton. Craniofacial dissociation. Okay, so in 3 there will be slight lengthening of the face can be seen. Neck trauma. In neck trauma, remember neck trauma is divided into different zones. And the bony landmarks which helps in, which are used to divide this neck into zones, that is important. Sternal notch, to cricoid cartilage is zone 1, cricoid to angle of mandible is zone 2, and angle of mandible to base of skull is zone 3. Okay, so this is the most important thing in the neck trauma. Most common zone in which injury occurs is zone 2. Zone 2 is the most common. Classification of blast injury. Again, see all the things which I have put in this DVT session. These are the important things which are asked in the last, you can say, 3 to 5 years of the paper. All that important things are there. Okay, so primary blast injury is because of the overpressure. So what happens in this? Wherever there is air, that air will expand and that will cause injury. So what are the areas? Middle ear, so that's why tympanic membrane is the most common. Then lung, then intestine, because these are the organs or the area where the air is there. So when the air will expand, these injuries will occur. Secondary blast injury is because of any penetration, any penetrating injury, any sharpnel, any sharp object goes, that is secondary. Tertiary is blunt injury. Suppose the patient is thrown in the air and the patient goes and hits some pole, hits some tree, that will be tertiary blast injury. Quaternary is because of burn or inhalational injury. Suppose blast occurs in a closed area, there is burn or inhalational injury. And quinary injury is radiation in case of like atomic blast and all, and infection. Okay, so this is the classification of blast injury. Okay, now we'll see in burns, the important thing is whenever the area there is some burn, that area histologically it is divided into 3 zones by Jackson's. Jackson's cutaneous zone. Jackson's cutaneous zone. Okay, so the innermost part is zone of coagulation. Here the maximum damage has occurred and the skin in this area is dead. Outermost is hyperemia. Okay, here there is minimum damage and the skin is viable. Underwater also, see underwater if the patient is totally inside, then middle ear is the answer. If suppose the neck is out, then lung is the answer. Now I don't know why people they ask this, because this is totally, I mean as whatever, I think this is kind of a baseless question. Nobody asks these kind of question these days. Okay, so you also, I mean, try to focus the recent thing rather than going 20 years back and some upset kind of questions. So don't go into those things. Okay, underwater, if the head is out, lung. If the head is also in, tympanic membrane. I'm still not able to understand how, I mean, underwater blast means some torpedo, something, and the person is looking, I mean, diving in the area of that war zone where the torpedoes are, striking against each other. I don't know who make these questions. Okay. So between zone of coagulation and hyperemia, there is zone of stasis, where there is moderate damage and the skin is vulnerable. Vulnerable means that skin may or may not survive depending on the vascularity of that area and depending on the infection in that area. Okay, now the percentage of burn. Rule of 9 is still followed, and this is the best way to calculate the percentage. In the adults, it is different. Hope you remember. The head and neck area is 9%. Each upper limb is 9%. Front of the chest and back of the chest is 18%. Front of the abdomen, back is also 18. Okay, 18. Lower limb is 18% and 1% is given to the perineum. Okay, so that is the rule of 9. Now, one thing I want to tell you, in case of children, it is slightly different. In children, at birth, this is at birth. Now, listen to me carefully. At birth, the only difference is this head and neck area becomes 18% and lower limb becomes 13.5%. Rest of the things are same. Just these two difference. Now sometimes they ask that what will be the percentage of head and neck at 5 years of age, at 4 years, 6 years, or the lower limb, because these are the two things which will change as the child grows. So at birth, this is the scenario. Now listen, okay, you can chat, you can write in the chat box 2 minutes later. See, at birth, this is the scenario. Now for every year, you have to add 0.5% in the lower limb, and you have to subtract 1% in head and neck till 9 years, when it will become same as adult. Okay, so now I'll give you one question. Tell me what happens at 6 years. At 6 years, what should be the head and neck percentage and what should be the lower limb percentage? Now this is the question for you. This is the question for you. Sacral region, see the lower back, okay, lower back up to the gluteal area, that is included in the back thing. So gluteal area will not be included in the lower limb. Gluteal area will be included in the back, not in the lower limb. Okay, so head and neck, you can see 6 years. So 18 minus 6, 12%. Lower limb, 13.5 plus 0.5 into 6 plus 3, 16.5. Yes, all of you got it correct. Okay, so remember this thing. If they ask age specific, you don't have to follow any, there are many charts, Lund and Browder chart, Burkos chart. Those, nobody can remember those charts. So just remember this easy, simple thing to calculate as per the different age. Okay, so for every year till 9 years, you have to add 0.5% in the lower limb and you have to subtract 1% in head and neck. At birth, the head and neck is 18% and lower limb is 13.5%. For every year, you have to add or subtract this thing. Now, if they mention neck separately, see, whenever we talk about head and neck, suppose 9%. In this 9%, 2% will be for neck. Okay, only 2% for the head and neck area is for the neck. So, although they will not ask, but suppose we always say head and neck 9%. If they ask only neck, then it is 2%. Okay, only neck will be 2%. At 9 years, yes, like adult. After 9 years, like adult. Roshan, Janvi. Okay, next, many times they give in the exam a picture and they will ask you what degree of burn it is. Okay, so if it is blister, 2nd degree superficial. Now, 2nd degree is also known as partial thickness. Superficial partial thickness. When there is, the skin is pale or mottled pink, it is 2nd degree deep or partial thickness deep. If there is eschar, it is 3rd degree, hard, black, leathery, 3rd degree. And if it is going up to the bone, up to the muscle, it is 4th degree. Okay, 1st degree is when there is only redness. There will be no blister, nothing, only red area. Okay, so I want you to remember this because see, this degree of burn or the depth is same in the frostbite. It is same in the bed sore or the decubitus ulcer. I have put both the things. So this is very important. You just, if you remember this, you can remember the other two also. If there is peeling of epidermis, peeling means it is 2nd degree superficial. Okay, if the epidermis is gone, it is 2nd degree superficial. Okay, so 2nd degree superficial, there will be blister formation. Okay, it will be painful and it will have blanch to touch. Okay, and it will heal without any permanent scar. Now, fluid resuscitation, the formula IV fluid is required in adults if there is more than 15% burn. In children, if there is more than 10% burn. If the burn is less than this, then you don't have to give IV fluid. You can give oral fluid that contains salt. So adult, the formula for this, the total amount of fluid in the 24 hours is 2 into weight into percentage of the total body surface area burn. Okay, whatever thing comes, you have to give half of that in the initial 8 hours and the remaining half in the next 16 hours. Initial 8 hours means the time from burn, not when the patient presented in the hospital. So mostly they don't ask that thing. So 2 into weight into percentage. Children, for calculation of fluid, children we consider less than 14 years. The only difference is here it will be 3. Rest of the things are same. And for electric burn, whether it is adult or child, total is 4 into weight into percentage. So just this multiplication factor, in adults it is 2, in kids less than 14 years it is 3, and electric burn it is 4. So whenever you are giving fluid, you have to, you should know that whether you are giving correct or not. So the best way to check is check the urine output, and if in case of adults, if the urine output is 0.5 ml per kg per hour, means you are giving adequate. In children, 1 ml per kg per hour, and in electric burn, 1.5 ml per kg per hour. Yes, very good, Akul Mittal. Yes, dextrose can be added to the children who are weighing less than 30 kgs. Okay, so this is the amount of fluid which you should give to the burn patient. Now, frostbite is, again, this is a cold injury when there is exposure to the temperature below freezing point. Below freezing point. So there can be in the cells there will be ice crystal formation. Like I said, first degree only hyperemia and edema. Skin is intact, like burn. Second degree, partial thickness. Third degree, full thickness. Fourth degree, muscle bone. Okay, so same like that. Just one thing I want you to notice here. In the second degree, there is a vesicle formation that contains clear fluid. Vesicle contains clear fluid. And in the third degree, there is hemorrhagic vesicle formation. Just one additional thing you remember. In second degree frostbite, there will be a blister which contains clear fluid. In third degree, there will be blood, hemorrhagic fluid. Yes, treatment is rapid rewarming. Rapid rewarming of that limb, 40 degrees centigrade temperature for 20 to 30 minutes or till the pink color appears. Colloids, don't get confused about these colloids and all. Okay, remember, in the burn, we give crystalloid only in the initial 24 hours. A and C, adult as well as child. Okay, sorry Yashika, it is electric burn, no matter whether it is adult or child, the formula is same. Trench foot is basically when there is exposure to the temperature less than freezing point. Okay, so usually the depth is not much in trench foot. The treatment will be same, but it will not be as deep or as severe as frostbite. Now, breast cancer, which is the most important cancer, you are supposed to know. Okay, the clinical presentation, mostly they come as a lump, and that lump, most common site is upper outer quadrant, followed by nipple areola complex, and the least common site is lower inner quadrant. Apart from the lump, there can be other features also. They can come with the ulcer, and these are satellite nodules. Then sometimes the whole chest wall is studded with the tumor cells, usually seen after recurrence after the modified radical mastectomy. The appearance is known as cancer and cuirass. Cancer and cuirass. In case of ductal carcinoma of breast, it can be invasive ductal cancer or in situ. The tumor cells, they can travel through the duct and come at the nipple areola region, causing itching, erosions, and ultimately eczema-like lesion, and the nipple areola complex will disappear. That condition, I hope you remember, Paget's disease of breast. Nipple areola complex, the NAC is nipple areola complex. Then the presentation can be of nipple discharge. What kind of discharge is significant or suspicious of malignancy? Single duct, spontaneous, and serosanguinous. Okay, so this is known as 4S. Single duct spontaneous serosanguinous type of discharge is suspicious of malignancy. Nipple retraction can be circumferential nipple retraction. And then sometimes when the tumor cells, they block the lymphatics, there is an orange peel-like appearance known as podi-orange or pudi-orange, whatever it is pronounced as podi-orange. So this is because of blockage of the dermal lymphatics. Cancer in cuirass is a French term. The meaning is armor's chest. Okay, they are comparing that appearance as the armor's coat, in which, like, when the people they go for the combat, there are so many hand grenades, there are magazines, so that is armor's coat. So here the comparison is the chest wall is having multiple nodules, multiple tumor cells, which is studied all over the chest wall. So that is the meaning, if you are asking what is the meaning of cancer in cuirass. Paget's disease, the tumor has to be ductal, either invasive ductal cancer or ductal cancer in situ. Paget's disease will not be possible in lobular cancer. Now see, whenever we do the surgery for the breast, like if you do modified radical mastectomy, after modified radical mastectomy, if you give radiation also in this area, so that radiation and the surgery will destroy the lymphatic. It has to be done actually. So that's why lymphedema is a common complication or sequelae which can be seen after you do the lymphedema, after you do the surgery for the, MRM and radiation. Lymphedema, the first thing you remember about lymphedema is it will not get cured. But yes, it can be controlled, and patient usually they can live with some there are conservative methods, lymphatic drainage and all we can do, and the patient they do well. But sometimes after 10 to 15 years of the lymphedema, it can convert into a lymphangiosarcoma or angiosarcoma of the arm, which is known as Stewart-Trevis syndrome. Now this Stewart-Trevis syndrome is an important question, that what is Stewart-Trevis syndrome? So Stewart-Trevis syndrome develops after 10 to 15 years of the lymphedema. There can be malignant transformation, that is Stewart-Trevis syndrome. This is a high-grade type of malignancy. You have to do amputation from the shoulder joint, that is known as 4/4 amputation. 4/4 amputation. Okay, so investigation of breast cancer, triple assessment. You have to first history and clinical examination. Second thing is a radiological investigation, and the third thing is tissue diagnosis. In the tissue diagnosis, remember, core needle biopsy is the investigation of choice. FNAC is not that good, so that's why core needle biopsy should be done. Radiological, age less than 40 years, the breast is more dense, so you go for ultrasound. Age more than 40 years, the breast is more fibrofatty, you go for the mammography. In the mammography, the important thing which makes you suspicious about the cancer is microcalcification. And on ultrasound, there will be a hypoechoic taller than wide nodule. Hypoechoic taller than wide irregular wall, and there will be posterior acoustic shadow. So these are the features on ultrasound which will make you suspicious that whether it is a malignancy or something else. Yes, popcorn will be seen in popcorn is a type of macrocalcification seen in fibroadenomas. Now based on the mammography, this is a scoring system, Biret score. I'm sure in radiology also in the classes this was mentioned by sir. Category 0 to 6. 0 is incomplete assessment, 1 is negative, 2 is when the findings are mainly benign, 3 is probably benign, 4 is suspicious of malignancy, 5 is highly suspicious, and 6 is when the patient already has biopsy proven cancer. So in case of Biret's 1 and 2, you have to repeat the mammography in 1 year. In Biret's 3, you have to repeat in 6 months. Biret's 4 and 5 are suspicious, so you are doing biopsy. And 6 mein to you already have the biopsy report, so that's why you go for the treatment. Taller than wide. Taller than wide, Divya. Hypoechoic, taller than wide, irregular borders. Okay, so this is Biorate scoring, breast imaging, reporting and data system. Something like Biorates, there is a ThyRates, that is for the thyroid disorder based on the ultrasound of the thyroid. There is PyRates, that is for prostate based on the MRI of the prostate. There is LYRates for liver based on the CT scan of the liver. But important one for you is Biorates. Okay, now TNM classification. First you see what is the meaning of if there is prefix C, P, R, T, Y. I mean it's not T, it is. These are the prefix which comes before the staging. So C means clinical, P means pathological, R means if it is a recurrent tumor, and Y is if you have given, patient has received chemotherapy. So you can say post chemo if you are doing the staging. And if there are multiple tumors, you will write M as the suffix. M is the suffix, multiple tumors. So if there are more than one tumor, you stage as per the bigger tumor, and you have to just write M in after you write it. That means there are multiple tumors and the bigger one you are staging. Okay, so C is not chemo. Remember, C is clinical. Okay, people, they do lots of mistake in this. C is clinical. Chemo means Y. Y means, from where this Y, chemo means there is systemic therapy. Okay, this systemic therapy. So that from where, from there the word Y has come, I mean the letter Y has come, systemic therapy. Okay, so TNM staging, like in all the 19 subjects, so many tumors and all, the most important TNM staging is the breast cancer. TIS is carcinoma in situ. T1 is when the tumor is 2 or less than 2 centimeters. There is sub-classification of T1 also. So that is T1. T2 is when it is more than 2 up to 5 centimeter. T3 is more than 5 centimeter. T4A is chest wall involvement. Now chest wall involvement means intercostal muscle, ribs and serratus anterior muscle. Serratus anterior muscle. Pectoral muscle involvement, latissimus dorsi, does not come in chest wall involvement. T4B is skin involvement, that is ulceration, satellite nodules or podi orange. Dimpling, nipple retraction, these are not skin involvement. T4C is when there is both skin as well as chest wall involvement, and T4D is inflammatory carcinoma. Now one thing I want to make clear here. See, suppose, just listen to this. Suppose there is a lump, and around the lump there is this podi orange appearance. Okay, this is suppose podi orange appearance. So this will go as T4B, skin involvement. Suppose there is a patient, there is no lump, there is erythema and this podi orange appearance only. Okay, there is no lump and this podi orange involving more than 1/3 of the skin of breast. Then that is fitting in the inflammatory carcinoma. That thing fits in the inflammatory carcinoma. In inflammatory carcinoma, there is no lump, there is erythema, edema, pain, tenderness, and that erythema and edema should involve at least more than 1/3 of the skin of the breast. That goes in inflammatory carcinoma. So if they ask question like that, it should be T4D. So don't do mistake in T4B and D. Just looking at the podi orange appearance, don't mark T4B. See, read the further question also, whether they are explaining, maybe they are explaining inflammatory carcinoma. Latissimus dorsi not involved in chest wall. Yes, correct, Neeraj. Okay, N1 is mobile axillary lymph node. N2A is fixed axillary lymph node. N2B is internal memory without axillary. N3A is infraclavicular. Infraclavicular is same as apical. N3B is internal memory along with axillary, and N3C is supraclavicular. And M0, M1 is no distant metastasis or metastasis. Remember, if there is contralateral lymph node involvement, then it is same as distant metastasis. It will be M1. Tumor is on the right side and axilla of the left side is having metastatic lymph node, lymph nodes enlarged, then it will be considered as distant metastasis. Distant metastasis. Pectoralis, see, suppose they say that the tumor is 5 centimeter or suppose 4 centimeter. It is involving pectoral muscle. What is the T staging? It will be T2 only. Okay, so in case of pectoral muscle involvement, latissimus dorsi involvement, dimpling of the skin, nipple retraction, you have to see the size of tumor. You have to mark as per the size. But suppose size is 4 centimeter and there is ulceration, then it will be T4B. So in T4, the size does not matter. Size has no importance in T4. So in those things, pectoralis, muscle involvement, latissimus dorsi, nipple retraction, dimpling, the TNM is based on the size. Staging of the contralateral lymph node, it is same as M1. It will be distant metastasis. Okay, so based on this this TNM, there is stage 1, 2A, 2B. So this stage 1, 2A and 2B is early breast cancer. Stage 3A, 3B, 3C is locally advanced breast cancer, and 4 is metastatic. We don't call it as advanced, we call it as metastatic breast cancer. Metastatic breast cancer, generally they don't have treatment options which can, the break is not possible. Okay, so don't ask for break again and again. Break will be given or may be given after my session is done, and that is not going to done soon, so you have to just bear with me. Okay, so surgery, we can go for modified radical mastectomy or breast conservation therapy. Modified radical mastectomy, we remove the whole breast as well as the nipple areola complex, the skin around it, and level 1 and 2 axillary lymph node. Okay, so that can be done for for early breast cancer, for locally advanced you can do this. Breast conservation therapy, in which you are not removing the whole breast. There are 3 components basically. In the breast conservation surgery, you are doing a wide local excision or lumpectomy. Then you are doing something for the axillary lymph node assessment. And in all the cases, you are giving radiotherapy. Radiotherapy, without radiotherapy, breast conservation is not complete. Now, axillary lymph node assessment, if the lymph node is palpable, then you will give a separate incision in the axilla and remove level 1, 2, plus minus 3. Most of the people, they don't remove 3. But suppose lymph node is not palpable. Lymph node is not palpable, then we go for sentinel lymph node biopsy. So now you know the role of sentinel lymph node biopsy. See, again, listen. If the lymph node is palpable, they are enlarged, it is metastatic, you go ahead and remove the lymph node. If it is not palpable, there are 2 possibilities. Either the lymph nodes are not involved, or there can be micrometastasis which has not yet palpable. So how will you make sure that it is not involved? So that's why you inject a dye around the tumor or around the areola. The dye is usually a blue dye, isosulfan blue is not used these days. We are using methylene blue. Okay, so methylene blue along with a radio labeled colloid sulfur. This is the dye which is given. Now the dye will travel through the lymphatics and you'll give a small incision in the axilla, and the first few lymph nodes, maybe 2 or 3 lymph nodes which has taken the dye from the tumor bearing area, you take out those lymph nodes, send it for biopsy immediately, frozen section, and if that biopsy says that there is tumor cells, you go ahead and remove all the lymph nodes in level 1 and 2, and if the biopsy says that there are no tumor cells, you can leave the axilla. Okay, you don't have to do any surgery for the axilla. Okay, so the basic meaning of sentinel is guard. Sentinel in Hindi, it is santri. Santri means the guard who is sitting at that. Suppose axilla is a colony. Okay, and there there is a gated colony. On that gate of the colony, these lymph nodes are sitting. Okay, so if you want to check, suppose you want to check in that colony whether the people have COVID or not. So what you will do, instead of checking each and every person in the colony, you will check the guard, because that is the only entry point of that colony. So if the COVID has gone inside, these guards will be infected. If they are fine, means the COVID has not gone there. Something like that we are doing here. These lymph nodes are sitting at the entry of the axilla. If these are involved, means the rest of the lymph nodes will also be infected. And if these are fine, means the tumor cell has not gone. So that's why you can leave the axilla behind. Okay, so that is the role of sentinel lymph node biopsy, which we are supposed to do if the clinically the axilla is okay. If clinically it is palpable, you don't have to do this sentinel lymph node biopsy. WL is wide local excision. You have to remove the tumor, taking some of the normal tissue around that tumor. Okay, wide local excision. So breast conservation therapy is a very good treatment. In fact, this is the most common treatment option used these days for the breast cancer, but it is not a treatment for all the patients. There are certain contraindications. Contraindication. Breast conservation therapy you can do in any case. You can do in early breast cancer. Okay, let me write this thing also. Breast conservation therapy in early breast cancer. If tumor is less than 5 centimeter, go directly for breast conservation therapy. If the tumor is more than 5 centimeter, then first go for neoadjuvant chemotherapy. Okay, now NACT is neoadjuvant chemotherapy. Don't ask again and again in the chat what is NACT. Neoadjuvant chemotherapy. After that, you go for breast conservation therapy. In locally advanced breast cancer, again, first you have to give neoadjuvant chemotherapy and then you can go for breast conservation therapy. So yes, breast conservation can be done in early as well as in locally advanced breast cancer. Early breast cancer, less than 5 centimeter, you don't need chemo. You can go straight away with breast conservation therapy. But if the tumor is more than 5 centimeter or if the tumor is locally advanced, then you have to give chemo first before going to breast conservation therapy. MRM can be done. Okay, MRM का भी देख लेते हैं. MRM, early breast cancer, you can go straight away for MRM. Locally advanced breast cancer. Locally advanced breast cancers are 3A, 3B, and 3C. In 3A, you can go directly for MRM. But in 3B and 3C, first you will give neoadjuvant chemotherapy and then you will go for MRM. Okay, so in MRM, we'll remove the whole breast from the second rib up to the inframammary fold, and after removing the breast and the nipple areola complex, you will remove level 2 and 1 axillary lymph nodes also. Level 3 may or may not be removed. Okay, so that is MRM. That is one incision which is reaching up to the axilla. You are removing the breast as well as axillary lymph node. In breast conservation, you have to give 2 incisions because you are not removing the whole breast. So one incision for removing the tumor and another incision for the axilla, either for the axillary lymph node removal or for the sentinel lymph node biopsy. Contraindications for breast conservation: absolute contraindication, pregnancy, especially first and second trimester. Third May, you can do the surgery and later on can give radiation. Pregnancy. Then if there is extensive microcalcification on mammography, extensive microcalcification, if there is diffuse positive margin after doing the wide local excision, if all the margins are positive, diffuse positive margin, multicentric tumor, and ataxia telangiectasia ATM gene mutation carrier. If these are absolute contraindication. Relative contraindication: prior radiotherapy to the chest wall. Then if there is connective tissue disorder like scleroderma SLE, persistent positive margin, persistent positive margin if there is increased tumor breast ratio and if there is BRCA 1, 2 or P53 mutation positive. So these are the absolute and relative contraindication. Connective tissue disorder. Yes, after neoadjuvant chemotherapy, if the patient wants breast conservation and there is no contraindication as such, you can go for either MRM or breast conservation depending on the patient choice and depending on the other factors also. Multifocal में हम कर सकते हैं. Multifocal में साक्षी we can do, but not in multicentric. Simple mastectomy usually these days we can do in ductal carcinoma in situ, or you can do as a palliative for fungating tumor. Okay, otherwise simple mastectomy people are not doing these days. Connective tissue disorder. Okay. Indications of treatment in general chemotherapy if the tumor is more than 1 centimeter and if the axillary lymph nodes are involved. I'm coming to that hormonal therapy. Yes, toilet mastectomy is the term not used these days, but it is palliative. Simple mastectomy was previously known as toilet mastectomy. Hormonal therapy to all the patients who are ER/PR positive. Radiotherapy to all the breast conservation therapy. And after MRM, in all the locally advanced breast cancer, positive margin, more than 4 lymph nodes positive or less than 10 lymph nodes in specimen. Cystosarcoma phylloids, you can do a simple mastectomy if the tumor is more than 10 centimeter. Okay, so in benign condition, yes, cystosarcoma is a indication. Targeted therapy for HER2/neu positive. So what is the regimen? HER2/neu positive, what you give? Trastuzumab. Trastuzumab, and if the disease is progressing on trastuzumab, you can add lapatinib. Lapatinib is the second line treatment option for HER2/neu positive patient. Radiation will give 45 to 50 gray. Total dose 45 to 50 gray, 2 gray daily. Hormonal therapy, premenopausal tamoxifen, postmenopausal aromatase inhibitor. Aromatase inhibitor. Usually I write AI, but again if I write AI you will ask like what is AI? So aromatase inhibitor. Chemotherapy mostly taxane and adriamycin based chemotherapy. Okay. Now after MRM there are options of breast reconstruction. Okay, so this is the flap reconstruction is much better. This is LD flap, which is based on thoracodorsal vessel. But LD flap can be used only for the patients who are having small breast because you don't get much of bulk there in LD flap. More bulk will be given by tram flap. See, this is transverse rectus abdominis myocutaneous flap. So tram flap can be a pedicle type of tram flap or a free type. Pedicle is based on superior epigastric artery and free is based on inferior epigastric artery. Free is based on inferior epigastric artery. Okay, so see what is transverse rectus abdominis myocutaneous. So you take the skin, subcutaneous fat and muscle from here and put it at the thoracic area where there is defect after removing the breast. Okay, so when you do this free type of tram flap, because you are taking muscle from here, So in this tram flap, usually the donor side becomes weak, and later on at that area incisional hernia can become. So that's why there is a modification of free tram flap that is known as DIEP flap, deep inferior epigastric perforator flap. Deep inferior epigastric perforator flap, DIP flap. The basic difference between this and free tram flap is that the muscle is spared. Muscle is spared. So because you are not taking the muscle, only the skin and the subcutaneous fat, so that's why the donor site will not become weak. So that's why later on the chances of incisional hernia will not be there. So today if they ask the question which is the best type of reconstruction after MRM, DIP is, if DIP is in the option, that should be the answer. Suppose this is not in the option, then tram, so definitely it will be there in the option, then that will be the answer. Both are there, DIP, mark DIP. DIP is the best type of reconstruction. Okay, so see this condition, this huge lump can be seen. This is the LD flap, latissimus dorsi. From this area you mobilize the skin, muscle and fat and bring it anteriorly, and later on nipple areolar complex can also be created. This huge tumor, big tumor, cannot be anything but phylloids. Phylloids are mostly benign. Sometimes there can be malignant transformation occurs in the form of sarcoma. Painful breast, tenderness, lactating female, breast abscess. Now if I ask you one more thing, what is the treatment of breast abscess? What will you write or what will you mark in that exam? Okay. Firm tender cord-like structure is Mondor's disease. And if there is slit-like nipple retraction, there is this fistula formation, green color discharge, then the answer is it is duct ectasia. Yes, those who are saying that you will do incision and drainage, make sure you don't mark this in the exam. These days the treatment is not IND. The treatment is you will give antibiotics plus you have to do needle aspiration. Okay, IND these days is not the first line treatment. This is the first line treatment, antibiotics and needle aspiration. Even after repeated needle aspiration, if there is residual abscess, then in those cases you might have to do incision and drainage. Or suppose there is skin necrosis, then you have to do incision and drainage. Otherwise, IND is not the first line treatment for breast abscess these days. Okay, so make sure you don't mark it wrong. Okay, these are the methods of palpation of breast. This one, the first one is the dial clock method. Second is vertical stripes method. The C is the wedges. And fourth D is concentric circle. So some clinical type of clinical examination questions they also ask. Okay, so now vascular system, very important, recent CEAP classification. I'm sure you remember C0 is when there are no signs of venous disease. C1 is telangiectasia or reticular vein. Okay, I hope you will not ask me to write it full because this is not the first time you are listening or reading these things. C2 is varicose vein. C2R is recurrent varicose vein. C3 is edema. C4A is hyperpigmentation or eczema-like condition. C4B is lipodermatosclerosis or white patch like atrophy blanche. Okay, see, just let me clear one thing. Suppose in this session, if there are like second year, third year students, or those students who are not going to give exam immediately, if you're sitting there, it is going at a, because it is a revision, so we are going at a pace. If you see in the class, we take time to explain all these things, we show all these images. Okay, so because it is a revision, don't compare this with your the normal usual classes. Surgery we teach for like 6, 7, maybe 8 days, 9 days we teach. And here, not even in 9 hours we are finishing. It is, I guess 7 hours we are finishing the whole surgery. Okay, so it cannot be, I mean, you cannot compare these DVT session with your normal classes, not even T&D. Okay, this is just a revision. You know these things, and I'm just brushing out these things, and maybe in the exam, just before the exam, this is a quick revision kind of thing. Okay, so don't think that I'll explain each and everything. So again, I mean, the time is limited, so instead of missing out the important points, I'll just go through touching these things so that you remember and you know that these are the important things. C4C is corona phlebiactatica. Okay, C5 is healed venous ulcer. C6 is active venous ulcer, and C6R is recurrent venous ulcer. Varicose vein size criteria. Varicose vein, you will say if the size is 3 or more than 3 mm in the diameter. If it is less than equal to 1 mm, it is telangiectasia. 1 to 2.9 mm is reticular vein. Okay, these things should be clear. Okay, one thing is missing, EC. EC means when the etiology is congenital, P means primary, S means secondary, N means when no etiology identified. P stands for pathophysiological, R means reflux, O means obstruction, R and O means reflux as well as obstruction, and N means when no pathophysiology identified. Anatomical, S means there is problem in the superficial system, D means there is problem in the deep system, P means there is problem in the perforators, and N means when no anatomical site identified. C2R is recurrent varicose vein. Okay, Srinath, recurrent varicose vein. Okay, so this is CEAP classification, and remember in this CEAP classification, especially in the C point, this C wala, somebody was asking to show again. Suppose it is written C2, and if it is mentioned here as A, so this A means asymptomatic, and suppose C2S, S means symptomatic. Okay, this was a neat question. A is asymptomatic, S is symptomatic. AP is perforator. Okay, there is in the lower limb there are superficial system, deep system, and small veins which act as a communication between superficial and deep. Those are known as perforators. Okay, so perforators. P, N, everywhere N is when you don't have any idea that what is the pathophysiology or what is the etiology or what is the anatomical site. N means no means no idea. You don't know that where is the origin of this. Okay, now there are certain clinical tests. The first test is the Brody-Trendelenburg test. Brody-Trendelenburg. Okay, Brody-Trendelenburg, one is to see the SFJ incompetence, and 2 is to see the perforator incompetence. Okay, now don't if I'm sure you know these tests, but it is not possible to tell you that what we do in these tests, that itself is 1 hour topic. So this is Brody-Trendelenburg test. This is the multiple tourniquet test. This is for perforator incompetence. Perforator. The third test, the name is Fegan test. This is also for perforator. I'll write just perforator. This fourth one is modified Perthes test. This is to rule out DVT, to rule out deep vein thrombosis. Then if there is a positive cuff impulse, positive cuff impulse, this is Morris's test. Morris's test. Positive cuff impulses, Morris's test. Yes, very good. Malabi. This is Schwartz test. Schwartz test indicates a continuous column in the vein, and the last one is the Pratt test, that is also for perforator incompetence. Yes, Khasi, Morrissey, fine. Okay, so these are different clinical tests in the varicose vein to know whether this problem is because of SFJ incompetence or perforator incompetence, or whether the patient is having DVT or not. So these are the different tests. Recently in the INICT they had asked about this. Okay, Brody, Trendelenburg, 2 is for perforator incompetence and 1 is for the SFJ incompetence. Okay, now the treatment option for varicose vein. This treatment option is in which we'll make small openings and put the endoscope and see the perforator, clip the perforator and cut the perforator. That is subfacial endoscopic perforator surgery. Subfacial endoscopic perforator surgery. In this test, we put a catheter in the vein and we'll burn the vein from inside. We ablate the endothelium so that the vein becomes fibrous, cord-like. That is endovenous ablation. If you are ablating that endothelium of the vein by the thermal energy, that is known as radiofrequency ablation. If you are using with the laser, then it is known as endovenous laser ablation. Okay, so endovenous ablation is the treatment of choice for varicose vein these days. We don't do open surgeries frequently in varicose vein. Okay, so this is a treatment of choice, endovenous ablation. And this method in which we are injecting a chemical inside the vein so that the vein becomes fibrosed, that is sclerotherapy. Sclerotherapy, we make a foam and the chemical is sodium tetradecyl sulfate. Sodium tetradecyl sulfate is the chemical foam sclerotherapy. But remember, sclerotherapy is mainly done for the telangiectasia and reticular vein. It is not the treatment for varicose vein per se, it is for small veins. This is the open surgery, which is, like I said, not done these days. This is Trendelenburg surgery. Trendelenburg surgery is basically flush ligation of GSV and flush ligation at the SFJ and stripping of GSV. These days, the endovenous ablations are the main treatment option. And remember, in Trendelenburg surgery, when we remove the vein, when we do stripping of the vein, we don't go up to the ankle level. We just we pull the vein just below the knee. We don't go up to the lower part because in the lower leg, the vein is very closely related to the saphenous nerve. And if you try to pull it out, you might injure the saphenous nerve. So that's why we don't remove up to the ankle. Okay, so that's why lower part there is saphenous nerve. Okay, this is what you are asking question. Okay. Investigation of choice for varicose vein as well as for DVT is venous Doppler or duplex scan. Venous Doppler or duplex scan. Okay. Deep vein thrombosis, Virchow's triad or the Furco's triad. What are the three things? Endothelial injury, stasis of blood, and hypercoagulability of blood. Now, if they ask most common site for DVT, most common site for DVT is the soleal plexus vein in the calf. Now we know why we are scared, or why most of the people, especially surgeons, are scared of the DVT, because that thrombus in the veins in the calf that can break and go proximally and can cause pulmonary thromboembolism. But usually the calf vein DVT does not go proximally. Those DVTs, they form, they dissolve. It is the DVT of the femoral vein and the iliac vein which more commonly causes pulmonary embolism. Okay, so that is femoral vein or iliac vein DVT. That is more prone for the proximal thromboembolism. Okay, so this is about DVT. Treatment of DVT. See, treatment of DVT, we start with the low molecular weight heparin. When we do stripping of vein, these days we don't do stripping of the vein. It is a older treatment option, although many people they are doing it, but it is not recommended these days. Acrylate can be used. Acrylate is a different treatment. That is a tissue glue option. That we don't call it as sclerotherapy. We don't call it as sclerotherapy. That is a tissue glue. That is a different option. Low molecular weight heparin, which is given subcuticular injection, and then after maybe 5 to 7 days after low molecular weight heparin, you put the patient on oral anticoagulants. Previously, the oral anticoagulant which was preferred was warfarin, but now we don't give warfarin, we give new drugs like rivaroxaban. Okay, I'll write both the names, warfarin or rivaroxaban. This is the main drug these days, indirect factor 10A inhibitor. Yes, novel oral anticoagulant, NOAC we call them as. ABPI is ankle brachial pressure index. We check the pressure at the ankle, and in ankle we have to see 3 vessels, okay, dorsalis vides, posterior tibial and peroneal. Among these 3 vessels, whichever is having the maximum pressure we'll put in the numerator, and denominator is we'll see the pressure in the arm. So that is ankle brachial pressure index. In this image they are showing this is the handheld Doppler. So ABPI we check by the Doppler, okay, not by putting a normal sphygmomanometer. We check using the Doppler. What is the pressure in the dorsalis vides, posterior tibial and peroneal? Among these 3 vessels, whichever is having the maximum we'll put as the numerator. Denominator is the brachial artery. Normally it is 0.9 to 1.4. 0.9 to 1.4. In the calcified blood vessel, it will be more than 1.4. If it is less than 0.9, means there is some arterial occlusion. Intermittent claudication will occur when it is less than 0.7. Rest pain when it is less than 0.5. And if it is less than 0.4, it is critical limb ischemia, means very soon the patient is going to develop gangrene. Okay, less than 0.4. 3 vessels, dorsalis vides, posterior tibial artery and peroneal, and denominator brachial. So we have to see among these 3 whichever is having the maximum pressure. Okay, now so in case of see, one more thing I want to tell you. What common mistake people do is, suppose there is a question, 65-year-old male who is having 30 years history of smoking. Okay, he is smoking for the past 30 years, comes with chronic occlusion. So what is the cause of this problem? What is the cause in this patient, a 65-year-old male who is having 30 years history of smoking? The 2 common causes of chronic arterial occlusion is atherosclerosis and Buerger's disease. Looking at the question, what will you mark? Whether it is Buerger's or atherosclerosis. Another name for Buerger's is TOA. Yes, remember it is atherosclerosis. Okay, don't just see the smoking thing. Buerger's is never seen in 65 years. The age of Buerger's is 25 to 40 years. This is the age of Buerger's. Okay, so in the question, if there is history of smoking, don't just see one thing in the question. There is a whole question. See the age. If it is like 40, 45 years or more, go for atherosclerosis. 50 years or more, atherosclerosis. Buerger's is seen in young middle-aged people. Okay. So the treatment option, this is just showing PTA with stenting. This can be done for the patients when there is narrowing in the subclavian vessel, iliac vessel. Okay, it is fine for subclavian iliac vessel. When there is aortic bifurcation block. Okay, this is the block, aortic bifurcation. So in these cases, we can do a aortobifemoral bypass. Okay, this is aortobifemoral bypass. And this material which we use for this aortobifemoral bypass, this is a synthetic material made up of Dacron. Dacron is the material. Yes, Lariche syndrome can occur when there is aortic bifurcation block. There can be intermittent claudication in the gluteal area, impotency, and weak femoral pulse. See, remember one thing, aortobifemoral bypass, although it is a very good surgery, very nice surgery, and the long-term patency is also good, but this is a very major surgery. You have to open up the abdomen, go in the retroperitoneum. Sometimes when the people come, they have like severe comorbid condition, very old people. So in those cases, you can go for this axillobifemoral bypass. Axillobifemoral bypass. This is not a big surgery. This can be done under sedation or local anesthesia also. Okay, so the difference between aorto and axillobifemoral is that in which case what is preferred, if the patient is fit enough for a long duration surgery, aortobifemoral, and if the patient is not fit, severe comorbid condition, then you go for this axillobifemoral bypass. For femoropopliteal bypass, the best material which is used is reversed saphenous vein graft. Reversed saphenous vein graft. Now this is the question. What is the best material to do a coronary bypass? What is that graft material? What is the graft material for coronary bypass? The best is internal mammary artery. That too left. Lima is left internal mammary artery. Next, reversed saphenous vein graft, and then radial artery. Okay, so these are the common vessels used for the coronary bypass. Dacron is mainly for the aorta. Okay, next image we'll see where there is a very huge swelling in the abdomen. This is abdominal aortic aneurysm. The typical site is infrarenal abdominal aorta, that is after the aorta gives the renal artery and before it bifurcates. That is the common site. Now, abdominal aortic aneurysm, indication for surgery. When to do surgery in abdominal aortic aneurysm? Indication for surgery is either the patient is having symptoms, but usually they ask what is the indication for surgery in asymptomatic patient. Asymptomatic patient. Lima, see again, before I wrote Lima, I said 5 times. First I said internal mammary artery. Then I said internal mammary. Then I wrote L. I said left internal mammary artery. I'll say 2 times more. Left internal mammary artery. Reversed saphenous vein graft, which is also written here. Radial artery is radial artery. I mean, it's not a short form. So indications for surgery in asymptomatic patient. 2 indications. Either the size, the diameter of the aneurysm is more than 5.5 centimeter. Okay, because if the diameter is more than this, there are high chances of rupture, spontaneous rupture. Or if the rate of growth is more than 1 centimeter in 12 months or more than 0.5 centimeter in 6 months. I hope now the writing is okay. I mean, the writing, the problem of writing should only arise when it is the first time we are listening something or writing something, or if it is a new word for you. Otherwise, I don't think writing should be an issue, but maybe probably some of you are doing it for the first time, so it's okay, I'll write clearly. 5.5, if they don't mention any gender. Suppose they mention gender specifically, which although they are not going to do, but in females it will be 5 centimeter cut off. Okay, because the chances of rupture is more in females if the size is more than 5 centimeter. So until unless they specifically ask female, you have to mark 5.5 centimeter only. Okay, now, okay, this was the indication for surgery. Now the treatment option, you can go for either a open surgery in which you will put a Dacron graft. This is a Dacron graft. One centimeter in 1 month, Arushi, the patient will become a the patient will blast like a bomb. If it is 1 centimeter in 1 month, you need to, you need to hold that patient inside the OT only. Okay, it is 1 centimeter in 12 months. It is iota we are talking. 1 centimeter in 1 month means in 12 months it will be 12 centimeters is one, that scale is 12 centimeters. Okay. So, open surgery is one option, but these days the treatment of choice is endovascular aneurysm repair. Okay, this is the treatment of choice. Endovascular aneurysm repair. PTFE is not the preferred thing, but yes, PTFE can be used in the femoropopliteal bypass. If the patient does not have a saphenous vein, then you can use PTFE. Okay, endovascular aneurysm repair. It is not a surgery, it is an endovascular procedure in which inside you go in that aneurysm area and just deploy a stent. So that is a treatment of choice. Now when you do endovascular aneurysm repair, there is a complication that the leak can occur. We call it as endo leak. So there are different types of endo leaks, like if the blood is coming from proximal end or distal end, proximal end is type 1A endo leak, 1B is from the distal end. If there is leak from the collateral vessels, it is type 2. If there is a defect in the stent graft, it is 3B. If there is component separation, it is 3A. If there is porous wall, it is type 4. And there is type 5 also. 5 is actually, we don't know what is the cause of this increase in the diameter of the aneurysm, but somehow the aneurysm is increasing. So there is no leak, there is no porous wall, but aneurysm diameter is increasing. We call it as endotension. The cause is not known, but the diameter is increasing, endotension. Okay. Next, classification of aortic dissection. It is already written here. DBK's 1 is the most common type. Here the dissection starts at the ascending aorta and goes up to the descending aorta. It can go up to the abdominal aorta also. Type 2 is the least common. It starts from the ascending aorta and goes up to the origin of major vessel. And type 3, it starts after the origin of major vessels and goes into the descending aorta. Okay, so as per DBK, it is 1, 2, and 3, and Stanford 1 and 2 of DBK is Stanford A, and 3 of DBK is Stanford B. 3A and 3B, see, the stent graft is usually like this. This is one piece of the graft. And another piece we put from the other side, this is the second piece. Okay, so suppose the main stent graft is only having a hole and the blood is leaking from here. It is 3B. Suppose this part gets separated and now the blood is leaking from here. This is 3A. So that is that component separation. The second component gets separated from the main component. That is 3A. And if there is a hole in the main body, then it is 3B. Okay, Aishwarya. Stanford A is emergency, B is not. Distal wala is not that emergency. Now see, you can differentiate these three types on the CT scan. You can see these three CT. Okay, these are the lungs. This is ascending aorta, and this one is descending aorta. And you can see this line which is shown by these arrows. So this is that dissection. So if you can see dissection in the ascending as well as in the descending, it is type 1. If you can see dissection only in the ascending, descending is fine, it is 2. And in 3, there is only the descending aorta will be having this dissection. Okay, so based on CT, you can differentiate all the three types of dissections. Okay. Thoracic outlet syndrome is a condition in which the brachial plexus, nerves, and the subclavian artery gets compressed when it is leaving the neck and going into the limb. So that's why this is the thoracic outlet. There are two outlets. One is towards the abdomen and another is towards the upper limb. So at this outlet towards the upper limb, when there is compression of the brachial plexus, nerves, and subclavian artery, that causes thoracic outlet syndrome. Usually it is usually this thoracic outlet syndrome, the main 90% of the symptoms are because of nerve compression, and that nerve compression occurs on the ulnar side. I mean, ulnar nerve is the main nerve root valley which gets compressed. So there are certain tests for thoracic outlet syndrome. In the exam, you will get the image-based as well as video-based question on that. So the first test is, if you have read this, this is Edson test. Okay, deep inspiration and rotation of the neck to the side on which the symptoms are there, Edson test. Second test, shoulder backwards and downwards, costoclavicular test. Costoclavicular test. Third test, the hyperabduction of the arm, it is right test. So in these three tests, Edson test, costoclavicular and right, you check the radial pulse of the patient, and on doing certain maneuver, if the radial pulse becomes weak, it means there is thoracic outlet syndrome. The fourth test is Roos test. You can see in this we are not checking the radial pulse. This just abduction, flexion, and ask the patient to open and close the fist, and if the patient is having pain on doing this maneuver, it means there is positive test. The last test is Allen's test. Remember, this Allen's test is not for thoracic outlet syndrome. It is for checking the radial artery and ulnar artery patency. Okay, so this is for Palmar arc patency, not for thoracic outlet syndrome. Okay, so Allen's is not for thoracic outlet syndrome. Next, see, in the thyroid, a midline neck swelling which is slightly above than the usual thyroid location. It moves with the deglutition as well as protrusion of tongue. This is thyroglossal cyst. The most common location is subhyoid. Thyroglossal cyst, the treatment of thyroglossal cyst is cyst trunk surgery, in which you have to remove the cyst as well as the whole thyroglossal duct along with the central part of the hyoid bone. Suppose somebody does an incision and drainage of the thyroglossal cyst, or infected cyst ruptures on its own, then it becomes thyroglossal fistula. There is an opening, and on asking the patient to protrude the tongue, you can see the indrawing of the skin at this area. That is known as Hood sign. Remember one thing about the fistula, that it is acquired condition due to mismanagement. Thyroglossal cyst is congenital condition. The treatment for fistula is also cyst trunk surgery. Yes, Hood sign, very good. Solitary thyroid nodule. Okay, there is a single palpable abnormality, solitary thyroid nodule. So after taking the history and the clinical examination, you check the TSH. If the patient is having hyperthyroidism, then you go for thyroid scan or the radioiodine scan. And if the patient is hypo or euthyroid, then you can go for ultrasound and FNAC if more than 1 centimeter. So mota FNAC is overall the investigation of choice. FNAC is the investigation of choice. Now I'll ask you, thyroid scan, what isotope of the iodine is used to do the thyroid scan? We'll do some radioactive isotope we give to the patient orally. What isotope? Iodine 123 or 131? Okay, so 123 is the main diagnostic isotope. Okay, so when you give this iodine 123, few nodules, they will not take up this, so that is cold nodule, and few nodules, they will take more than the rest of the thyroid, those are hot nodules. And few nodules, they will take same as the rest of the thyroid, those are warm nodules. So among hot and cold, in which case the chances of cancer is more? Cold nodule. Okay, there is increased risk of cancer. 15 to 20% chances of cancer is there. Iodine 131 for prophylactic? No, not for prophylactic. Iodine 131 is therapeutic. Okay, I'm sure Megha you wanted to say therapeutic only. Maybe some typo or autocorrection. Hot nodule is usually benign. Now FNAC based classification, this Thai 1, Thai 1, 2, there is 3A and 3B, 4 and 5. This is the European classification. European, or you can say British classification. More important, which people they follow, is Bethesda classification. Bethesda classification. Bethesda 1 is non-diagnostic, 2 is benign, 3 is atypia of unknown significance or follicular lesion of unknown significance, 4 is follicular tumor, that is, it can be follicular adenoma or carcinoma. Now FNAC cannot differentiate it is adenoma or carcinoma. 5 is highly suspicious of cancer, and 6 is when it is cancer. Okay, so this is Bethesda 1 to 6. Okay, so remember, if it is follicular tumor, remember this thing, follicular, it can be follicular adenoma or it can be follicular carcinoma. So if FNAC cannot differentiate, what will you do to differentiate a adenoma from a carcinoma? This is a question for you, tell me. What will you do to differentiate whether it is adenoma or carcinoma? You will do a hemithyroidectomy. And then in the hemithyroidectomy, when you send it for the proper histopathology, whether there is capsular or vascular invasion, will help you to differentiate whether it is adenoma or carcinoma. Yes, very good, hemithyroidectomy. Next we'll see comparative study of thyroid cancer. These are the 4 common types of thyroid cancer, the most common being papillary thyroid cancer, the least common being anaplastic cancer. Age group 20 to 40, 40 to 60, anaplastic, luckily elderly people, medullary 30 to 50. The most common gene mutation, BRAF for papillary, RAS for follicular, P53 for anaplastic, medullary, RET gene. Risk factor, just 2 important risk factors you see, papillary thyroid cancer, radiation, thyroglossal cyst, and Hashimoto. Follicular, multinodular goiter, and iodine deficiency. Nobody will ask anaplastic medullary, forget about that. Mode of spread, we'll see the most common mode of spread. Lymphatic, blood-borne, local for anaplastic, and medullary is also lymphatic. Most common site for metastasis, it is lung for anaplastic and papillary. Follicular, it goes in bone in the vertebra, osteolytic, bony, pulsatile metastasis. Medullary usually goes in liver. Histopathology, two important histopathology. In the papillary thyroid cancer, I am sure you remember there is orphan nei nuclei and samoma bodies. And in medullary thyroid cancer, okay, I'll write here only, there is amyloid stroma. Amyloid stroma. Yes, yes, all of you correct. Treatment, see, in papillary thyroid cancer, you can go for hemi or you can go for total. With or without level 6 and MRND. So modified radical neck dissection or level 6 should only be done if the lymph nodes are involved. In this case, follicular, mostly we go for total, with or without level 6 or MRND. MRND is modified radical neck dissection in case if you ask. Anaplastic thyroid cancer, mostly palliative, because it has, by the time it presents, it is already advanced. Important one is the last. That is always total. And in all the cases, level 6, so we need to remove, plus minus MRND. So modified radical neck dissection may or may not be required depending on the lymph node status, but level 6 you need to remove in all the cases. In all the cases. Okay, and one last thing about this, that there is no role of radioiodine scan or radioactive iodine ablation in medullary thyroid cancer, because medullary thyroid cancer has a different origin. It originates from parafollicular C cells, so that's why there is no role of radioiodine scan or RAI ablation. Tumor marker, yes, tumor marker if you want to know. In medullary thyroid cancer, the tumor marker is CEA and calcitonin. In rest, these three, the tumor marker is serum thyroglobulin. Because the other three, the first three, they arise from the follicular epithelium. So serum thyroglobulin. The medullary arise from the parafollicular C cells, so CEA and calcitonin. Okay. Next thing, inflammatory thyroid swelling. Hashimoto's, Decarvane's and Riedl's are the three types. Hashimoto being the most common. Hashimoto is the most common type of thyroid inflammatory swelling. Type of inflammation, Hashimoto is chronic, Decarvane's is subacute and Riedl's is fibrosing type, in which there is fibrosis occurs. Level 6 removal in medullary cancer even if it is not involved. And in papillary and follicular you will remove level 6 if it is involved. Etiology, Hashimoto is autoimmune. Decarvane is infection, the viral infection, and Riedl's is idiopathic. Okay, the exact etiology is not known. Antibody, the most common antibody is anti-thyroid peroxidase. Decarvane's and Riedl's you will not see. It is associated with HLA, B8, DR3 and DR5. In these the HLAs are not known. This is HLA basically B35, but they will not ask this. Age for all these, the age group is generally 30 to 60 years. So there is not much difference in the age per se among this. Clinical features, see in this case there will be hyper, then patient will become U, and ultimately patient will become hypo. In this also hyper, U, hypo, but ultimately patient will be euthyroid. In this the patient from beginning hypo, hypothyroid. Management, thyroxine is the mainstay in Hashimoto. It will resolve spontaneously, so that's why just symptomatic treatment in the form of some painkillers or steroids. And in this, steroids are the mainstay in Riedels. Okay. Yes, B8 can be seen in Graves also. Antibody. Now comes the Graves disease. It is like diffuse enlargement of the thyroid with toxic kind of goiter, which hypersecretion of T3, T4 and TSH will be low. Anti-TSH receptor antibody is the main. TSH receptor antibody. Investigation, when the patient comes initially, you will see the thyroid profile. You will see that TSH will be very, very low. Then you can go for radioactive iodine uptake, which will be high. Or you can see TSH receptor antibody in serum. These are the three main investigation. FNAC is not required in cases of Graves' disease. FNAC is not required. Okay, so now after making the diagnosis, medical management, antithyroid drugs like carbimazole is in general the drug of choice. Propylthiouracil is a drug of choice in pregnancy, first trimester. Okay, and along with that you have to add beta blocker. Beta blocker should also be added. Last slide, Mahima. Yes, aplasia cutis can occur if you give carbimazole in the first trimester, but PTU can have serious LFT dysfunction, liver function dysfunction. That's why we give only for the first trimester. Radioactive iodine ablation is the second line treatment option. We'll give iodine 131. Okay, absolute contraindication is pregnancy or lactation. Surgery is total thyroidectomy. That is the least preferred option. And remember, before surgery, you have to do preparation for surgery. Okay, you cannot take the patient like that. Preparation for surgery. Preparation means you have to give antithyroid drugs, beta blockers like carbimazole, beta blocker like propranolol, and Lugol's iodine is to be started usually 10 days before the surgery, which contains potassium iodide. Okay, if you take the patient directly like that, then during surgery it can release a very high amount of T3, T4 in the body, causing thyrotoxic crisis or thyroid storm. Very good, Robin, Sakshi. Okay, so complications of thyroid surgery: bleeding. Bleeding can occur in the post-operative period. Now this bleeding will present as airway obstruction. Now the treatment is, see, these days in the option you check if there is endotracheal tube placement. Then that should be the answer. Suppose it is not there, then open the wound bedside. Open the wound bedside. And after that, you can take the patient to the OT and control the bleeding. So, okay, so in airway obstruction, you have to do something at that time only. So depending on the option, if ETT is endotracheal tube is there, you should put that. Iodine 131, both gamma and beta rays are, emitted from that. Nerve injury, most common is external laryngeal nerve injury. But usually external laryngeal nerve injury is not a major problem unless the person is a professional singer and all. External laryngeal nerve injury, they present as there will be loss of pitch or tone of voice. Recurrent laryngeal nerve is dangerous on either side. If it is on one side, then there will be hoarseness of voice. If it is bilateral, then it can cause airway obstruction because the vocal cords will come in the midline. Hypocalcemia can occur because of the parathyroid insufficiency. Either the parathyroids are removed, all the 4 parathyroids, or there is ischemia. Remember one thing about hypocalcemia, this usually presents 2 to 4 days after surgery. So on the day of the surgery, on the next day of the surgery, hypocalcemia will not present. And thyroid storm is seen in unprepared patient of thyrotoxicosis. So when the gland releases excessive T3, T4, hyperthermia is seen. Hyperthermia, sometimes that get confused with the malignant hyperthermia. The drug of choice is propylthiouracil for thyroid storm. Okay, so these are the common complications of thyroid surgeries. These are the different examination methods. This is usually normally how you do the palpation. You go behind the patient and you, using your both hand fingers, you palpate. If you are standing in front of the patient and you are pushing one lobe and the other hand is used to palpate the thyroid, then this is Lahaye's method of palpation. For small nodule, you put your thumb and ask the patient to swallow. This is Kreil's method. For obese patient or the short neck patient, you ask the patient to put the hand behind the occiput and give pressure. That is Pizzillo's method. This one is the Pemberton sign. This is done for the retrosternal goiters. Okay, there will be flushing of the face. Okay, and this is to see the trachea, the position of trachea, whether it is midline or not. Okay, so you put 2 fingers, one on both the clavicular head, and using the middle finger you will trace the trachea. Sometimes when there is a huge thyroid swelling, that cause shifting of the trachea. Trail sign, yes. So not just for thyroid, for any condition, trail sign can be seen. Hyperparathyroidism. Okay, remember this parathyroid topic itself, although in 5 minutes we'll revise this, but this is one of the very important topic these days for the NB exams. Okay, recently there was a super specialty exam, NEET super specialty MCH exam. In that there were total around 150 questions maybe there. Out of those 150 questions, that is the whole surgery, 150 questions, but out of 150 there were around 15 to 20 questions only from the parathyroid. And only these things questions like primary hyperparathyroidism is because of adenoma, hyperplasia or carcinoma. Secondary is because of chronic hypocalcemia. And tertiary is when the gland becomes autonomous because of a prolonged secondary. First image, this is a normal, this is normal. Okay, normally if somebody asks you to go and palpate the thyroid, this is how you go and palpate the thyroid. I mean, these are also normal, these are not abnormal, but that is the usual way of palpating the thyroid. A usual way of palpating. Okay, so clinical features of hyperparathyroidism: stones, bones, groans, moans, overtones are the signs or the features you will see in case of a full-blown disease. These days, although the patient come early, so that's why mostly fatigue and polyuria, polydipsia, bony pain. These are the symptoms these days of hyperparathyroidism. Yes, believe me, if I show you, maybe if, although you are close to your exam, but if I show you the NEET SS paper, and if you have read the surgery, if you have read the notes once, out of 150, 90 questions I can give you in writing, you will mark correct. 90 questions you will mark correct. and the selection is at I guess 120. 120 is I mean a nice rank you will get. But yes, that is the exam, the beauty of the exam. People, after knowing the things, they do it wrong, and that will, push them back in the merit list. Okay, so investigations, X-ray, salt and pepper skull, although these are not specific. This is very important X-ray. There is loss of periosteal, there is periosteal erosion on the radial side of the middle phalanx. Technetium 99 sestamebe is the investigation of choice. Just remember this, in the exam they will not ask you spect with sestamebe and all, because see, in examination they ask the practical things. This we are doing surgeries of these patients. Okay, every year we do so many surgeries of parathyroid. We ask for sestamebe. Even if the patient is having paying capacity, we don't ask for spect and we don't ask for 4D CT and all these. Theoretically, those are the possible investigation, but investigation of choice if they ask technetium 99 sestamebe. Okay, the treatment is parathyroid adenoma, removal of the gland. So when you remove that involved gland, how will you confirm that you have removed the correct thing? The confirmation of removal is either you do a frozen section, or you can see if there is drop in serum PTH more than 50%, 10 minutes after removal. That is known as Miami criteria. Miami criteria is very good. Parathyroid hyperplasia, you have two options, either go for 3.5 gland removal or go for all 4 with auto transplant. And when you remove the auto transplant of the half gland, you will not put it back in the neck, you will put it in the brachioradialis muscle. Okay, forearm muscle of the non-dominant forearm. Usually they don't ask about parathyroid carcinoma treatment. It is usually the en bloc removal. En bloc removal means you have to remove the parathyroid along with the ipsilateral hemithyroidectomy. Okay, so this is the treatment of parathyroid. Men syndrome, men 1 name is Wermer syndrome, men 2A is Sippel syndrome, men 2B is mucosal neuroma syndrome. Men 4 is, although there is no name, but you can call it as men X syndrome. Sestamebe spect is not done, it is technetium 99 sestamebe. Okay. Sestamebe spect is a very costly investigation. Okay, so technetium sestamebe is should be the answer. Break, like I said, see, I'm also standing here and I'm feeling okay. You must be like much younger to me, and I'm sure we will be able to do. Okay, we are at 729. I guess there is 760, some 30 more pages. Okay, and later on you'll see. Later on there is mostly you have to see those things. Just 10 minutes, maybe 15 minutes more of writing. Then it is just image based. You have to just tell me the things. Okay, so I'm sure you will be able to do it. Okay, so you are just, in surgery we call it as that it's your commando training. Okay, so your commando training starts today itself. The gene, MEN1 gene, MEN2A and 2B, there is RET gene, and MEN4 CDKN1B gene. Tumors, parathyroid, pancreas, and pituitary. MEN2A, parathyroid, pheo, and medullary thyroid cancer. Pheo and medullary thyroid cancer will be seen in MEN2B. but there are small benign mucosal and GI neuromas. And this MEN4 is mainly parathyroid and pituitary tumors. Parathyroid and pituitary tumors. Okay, parathyroid and pituitary. Oh, I'm fine. I see, as a surgeon, when we do surgery, sometimes the surgery goes for like 6 hours, 8 hours, 10 hours when we do Whipples and all. So it takes time. Those surgeries, although sometimes it happens in 4 hours, sometimes it takes 6, 7 hours. So we don't scrub out and we go and take break and all. So if we can do surgery in one stretch for 7, 8 hours, this is just maybe 3.5 hours. So that is absolutely kind of, it is piece of cake. So I'm absolutely fine. It's about you people. Okay, because maybe you have to write also, so you might be feeling a bit tired, but if you're sitting at your home, just have a cup of coffee and you'll be charged again. Okay, so ranula is a mucus extravasation cyst of sublingual gland. Extravasation. And remember, if they ask plunging ranula, it is a mucus retention cyst of sublingual as well as submandibular gland. Okay, so that is ranula and plunging ranula. Salivary gland stone. So looking at your queries, this is something that has come in my mind. See, most of the times, those things which you are asking, okay, I know that you know these things. Okay, I know this is a basic human psychology, that you ask that thing which you already know, and if I tell you that thing, you will be more happy in that. Okay, because this is the psychology. This is like while doing the revision also. Okay, we find very good and very energetic when we read that thing which we already confident about. And the thing which we don't know, we try to keep ignoring that. Okay, we'll read it later, and that later never comes. Okay, so I know that most of you, what questions you are asking, you know the answer. Okay, so if you know the answer, then why to ask again and again. Salivary gland stone, 90% of the stone is seen in the submandibular gland. Submandibular gland. And usually submandibular gland stones are radio opaque. And the treatment these days, open surgeries are rarely done, endoscopic removal. Endoscopic removal. And for ranula, if they ask the treatment, these days again the treatment is a bit different. These days the treatment is removal of the cyst along with the sublingual gland. If you leave the gland, there are chances of recurrence. So if this is in the option, that is the better treatment option. Okay, removal of the cyst along with the sublingual gland. Okay, and see, if you are saying that you are not able to write, anyways, you are. I'm sure they will give you this annotated PDF. So this is the session where you see the things, you listen the things as far as possible. Try to write it. If anything is left, you will get the PDF. So you can anytime you can note that in your notes. And already, like I said, these things are already in your notes. So nothing new I am telling you. Benign tumors, the common benign tumors. For the salivary gland, pleomorphic adenoma, which is the most common benign tumor, and overall also, and Warthin's tumor. Malignant is mucoepidermoid and adenoid cystic. Now I'll ask you, among these 4 tumors, one question I'll ask you. Which is the most, you can say, which tumor has the maximum chances of involving the nerve? Which spreads via nerve sheath? Adenoid cystic, okay, nerve sheath involvement spread via nerve sheath, which is radiation induced mucoepidermoid. Radiation induced, and also this is the most common malignant tumor, which can be seen in smokers, which can be bilateral Warthins. It can be bilateral, it can be seen in smokers. And pleomorphic is the overall most common type of tumor. Okay, so while doing the surgery for the salivary gland, if the tumor is involving only the superficial lobe, the treatment is superficial parotidectomy. If it involves the deep lobe, then you have to do a total conservative parotidectomy. In all the cases, try to save the facial nerve until unless the facial nerve is directly infiltrated by the tumor, and there are certain landmarks to identify the facial nerve. The common landmarks, 3 landmarks I will tell you. Tympanomastoid suture, posterior belly of digastric, and the third is cartilaginous part of the external auditory canal. Cartilaginous, EAC is external auditory canal. EAC is external auditory canal. Cartilaginous external auditory canal, that part is known as Conley's pointer or tragal pointer, like Smiley is there. So yes, tragal pointer, Conley's pointer is the same thing. Okay, so these are the important landmarks to identify a facial nerve during surgery. Okay, now most common nerve injured, or the common nerves injured in the parotid and submandibular surgery. First I'll tell you the common nerves, then I'll tell you the most common. Common nerves which are at risk of injury: facial nerve, then greater auricular nerve, and auriculotemporal nerve. Auriculotemporal. Most common, if they ask here, greater auricular. Submandibular surgery: lingual nerve, hypoglossal nerve, and marginal mandibular of facial. Here most common is this. Okay, so first of all, what are the nerve injury? What are the nerves at risk of injury? And the second thing is which is the most common nerve injury in these 2 surgeries. Okay, Fraze syndrome, just one thing, 2 things. What is this Fraze syndrome is gustatory setting, that is because of injury to the auriculotemporal nerve. And the second thing which I think can be asked as a question, that what is the treatment of choice these days? Okay, there is inappropriate regeneration of the nerves which are supplying which are taking the sensation of the, this taste, and they get inappropriately united with the nerves which are responsible for the sweating and erythema in that area. The treatment, remember, the treatment of choice is botulinum toxin injection. Botulinum toxin injection is the treatment of choice. I mean, there are other treatment options also, but this is the treatment of choice. Yes, Botox, botulinum toxin. Oral cavity cancer, I'll just tell you the potentially malignant disorder may high risk, and I'll tell you which is having the maximum risk. Speckled leukoplakia, erythroplakia, and dyskeratosis congenita. I want you to remember just these 3. These are the high risk potentially malignant disorder, means there are high chances that they will convert into a malignancy. And if I ask you which is having the maximum risk is speckled leukoplakia. Maximum risk is seen in speckled leukoplakia. Previously the answer was erythroplakia, but as per the new data, the maximum chances of turning into malignancy is in speckled leukoplakia. Okay, these are the common sites. All these tumors are squamous cell cancers. The oral cavity cancers are squamous cell cancer. Temporalis fascia graft, neurectomy, and all these things are also the option. What I asked you? I asked treatment of choice. That is botulinum toxin injection. Lip cancer, the most common site is vermilion border, that is the mucocutaneous junction. Buccal mucosa cancer, the angle of mouth is the most common site. Speckled leukoplakia, Aditya, speckled leukoplakia. Speckled leukoplakia is a kind of leukoerythroplakia. The inner part is white and there is an outer red layer. That is so that is a leukoerythroplakia, kind of a combination of that. And the tongue cancer, the most common site is lateral border of tongue. Medium risk, low risk, forget about that, nobody is going to ask. Okay, and treatment, see, squamous cell cancers are radiosensitive, so that's why if it is stage 1 and 2, low stage, you go for either surgery or radiotherapy. For 3 and 4, you have to do surgery as well as radiotherapy and as well as chemo. Vermilion border is Ashwini, that is the area where the skin ends and the mucosa starts, that is the mucocutaneous junction. Okay, oral cavity cancer, the most common site is tongue. Okay, transplant, the types of graft rejection, it can be hyperacute, acute or chronic. Hyperacute is because of mainly preformed antibodies. Acute, which occurs within 6 months, and that is because of B or T cell mediated. Chronic is from 6 months to up to years after the transplant, that is mainly cell as well as antibody mediated. So among these three, just tell me which is the reversible type of rejection. Only acute is reversible. Only this is reversible. If you can increase your immunosuppressant dose, then it is reversible. Candidiasis is not high risk. Okay, dyskeratosis, those three things which I told you, just remember those three things in the high risk. Okay, only acute is reversible. Now we'll see donor. Donor can be brain dead and circulatory dead. Brain dead donor, and DCD is circulatory dead. So brain dead donor, the criteria is when there is absence of three things. Yes, oral cavity cancer staging is important. So, I mean, what do you think, that only these things you are supposed to know what we are doing in the DVT? Then why we read, why we study the whole year? Okay, so then so there is just before the exam, 10 days, you do the DVT and you will remember also and you will clear the exam also. This is revision. Revision is revision. Okay, so don't say that if I'm missing out something, don't say that, okay, we'll not read that. Okay, are you going to read this one book and you'll go and give the exam? Okay. Absence of cranial nerve reflexes. Absence of any motor activity. And absence of spontaneous breathing. Circulatory dead donor. Circulatory dead donor category, this is Maastricht classification. Forget about organ procurement, just see category 1 is dead on arrival. Category 2 is failed resuscitation. Failed resuscitation. The patient had received CPR but somehow it was not successful. 3 is awaiting cardiac arrest. 4 is cardiac arrest in brain dead. And 5 is cardiac arrest in a admitted patient. So this is the original Maastricht classification. Admitted patient means the patient was already in the hospital, in the casualty, in the ICU, in the ward. The patient died. So obviously in the hospital we give the CPR, we do the resuscitation. So in the revised Maastricht, this 2 has gone, this 5 category has gone into 2. So in the revised there are only 2 categories. Out of these, category 3 and 4 are known as controlled donors. Others are uncontrolled. What all TNMs, that I'll tell you. Okay, that I'll tell you when I finish. What all TNMs, if you ask me just 1 TNM, then it is breast cancer. 2 TNMs, breast and oral cavity cancers. 3 TNMs, breast, oral cavity, and testicular cancer is also important. Okay, testicular cancer, renal cell cancer. 2 in urology. Prostate cancer, just remember the T staging, just the T staging. In renal cell cancer, in prostate cancer, just T staging. In testicular cancer, whole T and M, as well as what is stage 1, 2A, 2B, 2C. So that you need to know in the testicular cancer. So that is urology. Okay, testicular cancer complete, and prostate and renal cancer, just the T staging. Then GIT, colorectal cancer is 1 TNM, which is important. Rest other not important. In hepatobiliary pancreatic also, TNM is not important. Just remember in that I'll tell you also, in the gallbladder cancer, if it is limiting to mucosa, surgery is different, and if it goes beyond, the surgery is different. UW solution is a preservative solution. pH is like normal 7.4, osmolarity 320, temperature 4 degrees centigrade. Composition, there are lots of things, but I want you to remember one composition. That is lactobionic acid. Lactobionic acid, there is potassium hydroxide, sodium hydroxide, hexaethyl starch, adenosine, glutathione, raffinose. Lots of things are there, but one important thing you should remember. Okay, kidney transplant is a heterotopic type of transplant. We put the kidney at a different area. Now in this, I'll just tell you the order. Order of transplant, order of the anastomosis. This is suppose the graft. Graft means that organ, and this is suppose recipient. Okay, so the first thing you will do the anastomosis is renal vein. That you will anastomose with the external iliac vein of the recipient and to side. Second thing, renal artery. That you will anastomose with the external iliac artery and to side. And obviously the third thing is ureter. And it has to go to bladder. Okay, so this is the order 1, 2, 3. Liver transplant, MELT score is, and CTP score. CTP score we'll discuss later. MELT score is important score. The 3 things we see: creatinine, bilirubin, and INR. So based on these 2 scores, we will okay, how much time is left? Somebody said something. 34 pages left. Just tell me the time. Time is, there is, I guess, how much time is left? There is 1.5 hours. Easily I will finish. Okay, don't worry. Creatinine, INR, and bilirubin, these are the 3 things. So MELT score, more than 15 and CTP score more than 9, indication for transplant. Indication for transplant. See, the things which I'm telling you, nobody, if has anybody in any exam, be it MCH exam, nobody has asked what is MELD O or modified MELD or something else. Okay, I don't know from where you are reading these things. People sometimes, just because they think that, okay, they will tell something extra, so the students will think that, okay, this teacher is good and this institute is good or that. But that is not going to give you any additional advantage in the exam. Okay, they will never ask you what is modified MELD or MELD O or B or P or whatever. Okay, so don't unnecessarily keep on increasing your trouble or your hard work. There are certain things which are not supposed to be for you. Otherwise, just for the liver transplant, there is a book of like 5,000 pages. So you are not going to read. I mean, there is no point. You can read if you want, but it's not going to happen. It's not going to give you any benefit. Okay, so in the liver, the order of anastomosis, first is the suprahepatic IVC, second is the infrahepatic IVC, third is the portal vein, fourth is the hepatic artery, and in the end we'll do the anastomosis of bile duct. Okay, now in the heart transplant, first you will do the left atrial cuff, then pulmonary artery, then aorta, and in the end SVC and IVC. Now in lung transplant there is some controversy. Let me make you clear. If it is a single lung transplant or a double lung transplant, single lung transplant, first will go for bronchus, then pulmonary artery, and then pulmonary vein. But in double lung transplant, first bronchus, then left atrial cuff, that is pulmonary vein actually, and then pulmonary artery. Okay, so remember in the question what they are asking, whether they are asking single lung transplant or double lung transplant. If they don't ask single or double, consider it as single. And second thing, you see what is in the option. In the option, whether they have written pulmonary vein or they have written left atrial cuff. So if in the option there is left atrial cuff, means they are talking about the double lung transplant. Third in the liver is portal vein. Sakshi. Yes, somebody already answered. Okay, so this is the order of anastomosis. Now, survival of the graft. How does the graft survive? In the initial 48 hours, plasma imbibition. It takes nutrition directly from the bed. 48 hours to 4 days, inoculation. And the 5th day onwards, there is neovascularization, new blood vessel formation. Okay, those who are really asking for the break, I'm sure this will be a recorded session. You can see it later. Also later means maybe later at night or tomorrow morning. So if you really want to go and have a tea or maybe water, or you want to go to loo, why don't you go this? Anyways, you are going to see this in the recorded version. So it's not like you will miss something if you go for maybe for washroom or to go for a tea. Okay, now this is a very important question. Very important, and you take any paper in the last 3 years, this question has been asked many times. Superficial skin graft and a full thickness graft, the difference. Layers, there is epidermis and a part of dermis. Full thickness, epidermis and whole dermis. Instrument, what instrument is used? Humbee's knife. Humbee's knife in full thickness, you will use a normal scalpel. Donor site will heal spontaneously, and here you will need suturing. Donor site can be reused. Here you cannot reuse. Common donor sites like thigh, back. Here the common donor sites are those areas where the scar will not be seen, like post-auricular area, upper eyelid. Uptake of the graft is early in partial thickness. It will be a bit late in the full thickness. Coverage it can use to cover big defects. It is only for the small defects. Durability to the trauma is poor because it is thin, and it is better because it is thick. Color match is also better in the full thickness. It will be poor. Now see this thing, one thing which is confusing about this contraction, primary and secondary contraction. Primary contraction is when you take the graft from the donor site, at that time it contracts a bit, that is primary. And when you put it at the recipient area, after a few days it will again contract, that is secondary contraction. If primary, secondary is not mentioned, remember secondary is more important. And secondary is inversely proportional to the amount of dermis in the graft. Okay, so if the dermis is more, secondary contraction will be less, so obviously it will be like this. So if you remember just this point, that secondary contraction is the more important and it is inversely related to the dermis. So this is less. Now you just change the other signs. This will be more. So if this is more, this is less. If this is less, this is more. Okay, otherwise maybe at this time you can remember it somehow, but in the exam it is, again you get confused and you might mark the wrong answer. So just remember one thing which I am telling you, secondary contraction is inversely proportional to the amount of dermis, and then you will not mark it incorrect. Okay, so these are the important points or important differences between a partial thickness or split skin graft and a full thickness graft. In partial thickness, we will take only a part of the dermis, the upper part, papillary dermis, and in full thickness, we will take the whole dermis. Liver, order, Yashika, suprahepatic IVC, infrahepatic IVC, portal vein, hepatic artery, and in the end, bile duct. Flaps may mostly you get an image-based question. They will give you a flap and they will ask you what kind of flap is this. This is a advancement flap. And this is Burroughs triangle. Burroughs triangle, the base pay you will cut a triangular part, that is Burroughs triangle. Another thing is almost like advancement but in a semicircular form, so that is a rotational flap. Rotational flap, advancement flap. Incision in the form of V and closure in the form of Y is VY-plasty. And incision in the form of Y, closure in the form of V is YV-plasty. Okay, so in this VYYV, just remember, the first letter is how we give the incision and the next letter is how we close it. How we close it. This flap is bilobed flap, usually for nose. Bilobed flap. The next flap, this is a rhomboid flap in the GIT, sir was telling in the last session. Limburg flap is a type of rhomboid flap. Rhomboid flap. This one is a Z-plasty. Now in Z-plasty, sometimes they ask this question, that when we do a Z-plasty, what is the, in a standard Z-plasty, what is the angle and what is the gain in length? Okay, so angle is 60 degree and there is 75% gain in length. Okay, so in a standard Z-plasty, this is the scenario. There are different angles Z-plasty. There is 90 degree also. There is 45 degree, 30 degree also, but in a standard Z-plasty, 60 degrees is the angle and 75% is the gain in length. Yes, very good. Page number is 738. Preeti. Cleft disorders, again 2 questions just. How does the formation of cleft occurs? See, in the cleft disorder there are 5 facial prominences or the processes. One is frontonasal. In this frontonasal, in the midline there is median or medial nasal process. Let's call it as medial nasal process. These are maxillary process. Lower one is mandibular. Now mandibular has nothing to do with the cleft disorder. In maxillary there is palatine shelves. Palatine shelves. So one question which they are asking again and again in the exam is how the cleft lip formation occurs. Cleft lip, just one question and just one answer. Non-fusion of the medial nasal process with maxillary process. Okay, non-fusion of medial nasal process with maxillary process. Just one question, nothing else. Okay, cleft palate is because of non-fusion of the 2 palatine shelves which are the part of maxillary process. V is incision and Y is closure. Yes, Abhishek, absolutely correct. Now the timing of cleft lip and palate repair. If it is cleft lip, then 5 to 6 months. And in bilateral, 1 month earlier, 4 to 5 months. Soft palate alone is 6 months. Now the cleft of hard palate, that is not possible. It's not possible that there is cleft of only hard palate. There is cleft of either soft palate alone or hard as well as soft. So if there is hard as well as soft, then 2 stages. At 6 months you will repair the soft palate and 12 to 15 months you will repair the hard palate. And same if there is a combination, 6 months you will repair lip and soft, not different, the same thing, 12 to 15 months hard palate. Okay, so this is the timing of repair. Okay, I guess Akul, this was what you are asking. So these are the 2 important things in the cleft disorders. Okay, next question, the difference between hypertrophic scar and keloid and the treatment of keloid. Extent, keloid goes beyond the original boundary. Beyond original boundary. It does not go beyond the original boundary. Etiology, in both the cases there is excessive collagen. Here also excessive collagen, here also excessive collagen, but in keloid this collagen is disorganized. In hypertrophic scar usually that collagen is arranged in a parallel fashion. Time taken, usually it will occur within 4 weeks of the initial incision or the trauma. This usually takes after 3 to 4 months, sometimes even after a year it can occur. Site flexor surfaces of the body, this you all know, I am sure, sternum, shoulder, earlobe. Pain is not there, it will be seen in keloid. Itching is not in hypertrophic, it will be seen in keloid. Family history is not there, it will be seen in keloid. Usually it goes in autosomal dominant inheritance pattern. Management, mostly you just need to remember about the keloid, that is the first line treatment is intralesional steroid, and I'm sure you know the name of the steroid, triamcinolone. triamcinolone. Type of collagen, if you are asking, Ujjwal, both type 1 and type 3 collagen will be seen in keloid as well as in hypertrophy scar. Both the types, type 1 and type 3 also. Okay, so this is a typical picture of a keloid. You can see it has gone to the surrounding area, and hypertrophy scar is just an elevated kind of scar. Okay, this is round body needle. Round body needle usually for delicate structures. Delicate structures. If recurrent keloid, then there are other options. You can give radiotherapy, you can give 5-fluorouracil injection, there are options of pulse dye laser, then there are other options. You can give other drugs intralesional, there is imiquimod, there is bleomycin. Okay, but that is in the proper class. We tell if not this, then what, then what. This is a revision class, so we'll focus on the important things. This is a cutting needle. Cutting needle, and this is reverse cutting. These are for tough structures. Tough structures like bone, then skin, fascia, cartilage. We use these kind of needle, cutting or reverse cutting. For delicate structures like bowel, vessel, we use peritoneum, we use round body or tapered needle. This is the big blade. This is for big incision. Okay, number 20 to 24, they will be like this, and we hold it by dinner knife holding fashion, and the angle with the surface should be 30 degree. Angle with the surface is 30 degree. Another blade, although they write the size on the blade, but in the exam usually they hide this. This is 15 number blade. And this is for small incisions. Small incision, more precise incision. Hold it like a pen holding fashion, and the angle should be 45 degree. And this is 11 number. This is known as stab knife. Okay, usually for 90 degree angle, IND, venotomy, arteriotomy. For that we will use this kind of blade. Okay, this also you hold as a pen holding fashion. Only the bigger blade you hold it like this. That is the dinner knife holding fashion. This is the way you hold it. Rest of the blades you hold it like a pen holding fashion. Okay, about the knot, this is, see this first one, this is not actually a knot, this is beginning of a knot, and this is known as half hitch knot. Half hitch. Okay, then there are two types. One is square knot and one is granny knot. Okay, I have given the colorful version also so that you can differentiate. Okay, you have to see these threads which are coming out of the loop. If both the threads which are coming out are symmetrical, like in the first picture you can see both are coming over the loop. Like you can see the image here, like the red one. Both are coming over. So that's why it is symmetrical. So S for S square. In the other picture you can see one is coming over the loop and one is going under the loop. So if it is asymmetrical, it is granny. Okay, so all you have to do is just see one side. That on one side there will be one loop and two threads which are coming out of that loop. If both the threads are symmetrical, either both are coming over or both are going under, then it is square. If one is going over, one is going under, then it is granny. Okay, and if the first knot is a double half hitch like this, then it is surgeon's knot. And there is a type of knot which the surgeon uses his finger and thumb instead of the needle holder. So that is at the end of a continuous suture, Aberdeen knot. Aberdeen knot. Okay, so all these will be asked as image-based question. Okay, in a continuous, suppose there is a continuous type of suturing, and so in a continuous type of suturing, suppose X is the length of the tissue which you are suturing. So what should be the minimum length of that thread? How many times of the length of the tissue? Okay, remember 4x. And this is in the simple interpreted suturing. The rule is, the needle should always go 90 degree to the perpendicular to the surface, and whatever is the thickness, suppose X is the thickness, you have to go X distance from the edge on one side and X distance from the edge on the other side. This is where you put the needle and you bring out the needle. And the next suture you should take is twice the thickness of the tissue, 2x. These are the general rules of the suturing. Okay, now this is, suppose this is a type of mattress suture, A and B. Among this A and B, one is vertical mattress and one is horizontal mattress. Just look and tell me which is vertical and which is horizontal mattress. Which is the vertical mattress type and which is the horizontal mattress type of suture. Okay, surgeon's knot is this one. Okay, surgeon's knot. See, in this granny and square, the first initial is what? Initial is half inch. Over the half inch, we are doing something which makes it either a square or granny. In the surgeon's knot, the first one is a double half inch. You can see there is 1 half inch and 1 half inch. So you will take 2 throws and then you will put 1 knot above. So then it becomes surgeon. Okay, if there is double half inch, it becomes surgeon. Yes, A is vertical mattress suture and B is horizontal mattress suture. Horizontal mattress and A is vertical mattress. Very good. Okay, all you have to do is see this side is the knot, this side is the knot. Just see the direction of the thread on the other side. On the other side, if it appears horizontal, it is vertical mattress, and if it appears vertical, it is horizontal mattress. Okay, so in the exam, if there is any confusion, you have to see the direction of the thread opposite to the knot side, and if it looks vertical, that suture is horizontal mattress. If it looks horizontal, that suture is vertical mattress. Okay, Aberdeen knot is, we use the thumb and finger. Okay, you will not get any picture like this for the Aberdeen knot. Aberdeen knot is this only. The last knot in a continuous suture, surgeon uses his or her fingers or thumb to put that knot. Surgical site infections, Southampton grading and asepsis score are important in the NEET. They have asked this question. Grade 0 is when there is normal healing. Normal healing. Grade 1 is there is normal healing with bruising and some erythema. There is bruising and some or mild erythema. 2 is erythema and other signs of inflammation. Other signs like there will be pain, tenderness, redness, all these things. 3 is when there is serous or serosanguinous discharge. I am writing DS. DS means discharge. Wound mein DS is discharge. Serous or serosanguinous discharge. 4 is when there is pus discharge. And 5 is usually deep infection, which can include the tissue breakdown also. Tissue breakdown. Okay, so these are the, this is the Southampton classification of the wound. Asepsis score. Asepsis score is actually, asepsis itself is a mnemonic where A stands for additional treatment. Additional treatment means whether the patient needs any prolonged antibiotic or any drainage of the pus or any debridement of the tissue. Yes, very good, Anjali. Additional treatment requirement. S is serous discharge. E is erythema. P is pus discharge. S is separation of tissue. I is isolation of bacteria. Sorry for the handwriting, but I guess all of you are like medical students. You know, if I write ERYTH and then something else, you should know it is erythema. And S is stay in hospital for more than 14 days. Yes, very good, Shravan. Stay prolonged for more than 14 days. So this is asepsis score. This is what there is. Actually, this is a score. There are certain points are given for all these things. But in the exam, they will ask all of the following things are seen in asepsis wound scoring system except. So it's not important to remember the points exactly what are given for all of these features. You just need to know what are the things in this Southampton and asepsis wound score. Okay, so these are the three types of necrotizing soft tissue infection. If it is limited to extremity, it is necrotizing fasciitis. If it is involving the abdominal wall in a post-op patient, that is known as Melanese gangrene. And if it is in the scrotal area, perineal area, it is Fournier's gangrene. Okay, so necrotizing fasciitis, Melanese gangrene, Fournier's gangrene is kind of the same disease involving extremity, abdominal wall, and the perineal region. Usually, the underlying muscle in necrotizing fasciitis and Melanese is okay, and in Fournier's gangrene, the testes are generally not involved. Okay. Decubitus ulcer is the pressure ulcer. Pressure ulcer, or people call it as bed sore also. So this is, see, when the patient is not moving and the patient is immobile, paralysis, paresis. So the patient is lying down. There is one hard area is the bone, another hard surface is the bed. So between bone and bed, that pressure goes on the skin, and when the pressure is more than 30 millimeter of mercury, the capillary flow decreases, and prolonged decrease in that capillary flow leads to ischemia and results in decubitus ulcer. So decubitus ulcer is basically a type of arterial or ischemic ulcer. Okay, most common site is, ischial tuberosity is the most common site. Ischial tuberosity. Then sacrum and the other areas. Okay, so here also I told you in the staging, stage 1, just erythema, intact epidermis. Stage 2, partial thickness. Stage 3, full thickness. Stage 4, muscle, bone and tendon. Okay, and there is one more, stage 5. Stage 5 is, suppose there is a decubitus ulcer and on that there is a scab covering it. Scab covering it, or eschar-like hard layer covers it. So until unless you remove that scab or eschar-like layer, you will not know how deep it has gone. So that's why stage 5 is known as unstageable. Unstageable. Okay, treatment is you need to do the debridement. You can do negative pressure dressing. Okay, treatment, debridement, negative pressure wound therapy, minus 125 millimeter of mercury is the pressure. Sometimes this hyperbaric oxygen therapy also helps. Hyperbaric oxygen therapy. And in prevention, you need to turn the patient. Okay, this is also they ask. You need to turn the patient if the patient is supine every 2 hours. If the patient is on wheelchair, every 10 minutes. You just ask the patient to lift a little bit. Okay, so these are the important things about decubitus ulcer. Yes, muscle is generally not involved. Just change the position or turn the patient. These are the different IV lines we have discussed so many times. Don't do any mistake in this. 14, if you see the gauge size, 14, 16, 18, 20, 22, 24. If I talk about the flow rate, the maximum flow rate through these cannulas, 240 ml per hour. This is 180, this is 90, this is 60, this is 36, this is actually 20 ml. Okay, so the maximum flow rate and the size of these cannulas. Gray cannula is preferred cannula for the trauma and the shock patient. Gray, I mean 16 is the ideal, 18 is the minimum size for the patients who come in shock or with the severe bleeding. Wheelchair, yes, 10 minutes. Okay, you also, when you sit, you sometimes you just do like this now, so that the person also has to just lift himself for 10 minutes. I mean, every 10 minutes he should lift himself. Not if he keep on lifting himself for 10 minutes, then it will be very strong triceps. Okay, just every 10 minutes he has to just do like this. Okay, so that the flow starts going and it will not prolong. 240, it is 240, not 270. White, I mean there might be white cannula, but see, I am in this surgical branch for almost 13 years. I have never seen a white cannula in my life, and I have worked in all the big hospitals. I have not seen a white cannula. Maybe if it is there theoretically you can write, but I don't think that they are going to ask. Okay. So see, there are different types of drain. There is one type of drain which is known as open. Open means one end is inside, the other end is opening either directly into the dressing or outside environment. So these are the open type of drain system. Open drain. This is corrugated rubber drain. Corrugated rubber drain. This one is Penrose drain. So they are open drain system. Then there is a closed drain. Closed drain means one end is inside, the other end is outside in a bag, in a pouch, in a container. So there are two types. One is closed non-suction drain. Like these two, abdominal drain and ICD. This is ICD, this is abdominal drain. And then another is closed suction drain. These are two closed suction drain. This one is Jackson Pratt and this is Romovac. Romovac. Yes. Okay, so these are the common drain types. Now the instruments. Okay, the initial C9 retractors. I'll write the name. Devers retractor. Devers retractor. Langenbach retractor. Balfour retractor. Zerny retractor. Doyens, Morris, cat's paw, single hook, and Joles. All these are retractors. Retractors. Then I don't know if this is visible or not. In your book it must be visible. This is mixture right angle forceps. This was asked recently in the exam. Mixture right angled forceps. That instrument in which you see a longitudinal groove, that is needle holder. This serrated type of jaw which is used to hold the tough structure is Ali's forceps. And another, this flat type which is used to hold the delicate structures like bowel, Babcock's forceps. Yes, I can see most of you know about these common surgical instruments. This, I'm sure you know, this is Veris needle, a spring-loaded needle, very frequently asked in the exam. Okay, it is used to create pneumoperitoneum. It is used to create pneumoperitoneum, which is done in the beginning of the laparoscopic surgery. Ryle's tube. Two things about Ryle's tube or the nasogastric tube is how to measure the length of Ryle's tube, that how much inside it should go. NEX, nose, ear and xiphisternum. This much it should go inside. And what should be the position of the patient while sitting with neck flexed. Neck flexed. Foley's catheter. This is in general the Foley's catheter. The only thing they ask on the Foley's catheter is, okay, these are the four types. The fourth type is generally they don't ask. This is without any bulb. This is for patient who use self-catheterization. Neurogenic bladder, self-catheterization. This is three-way Foley's. Three-way Foley's is for bladder irrigation. Bladder irrigation. Patients of hematuria. This is Caudet tip catheter. Generally they don't ask. This is for patients of BPH. BPH patients. Supine may ideally you should not put. If you have done, then you are lucky that the patient did not aspirate. Okay, you should not do in supine. Okay, the patient might aspirate. One thing which they ask in the Foley's catheter is, which have been asked in the past, is what do you mean by French? Okay, French is the outer diameter. And when French is equal to 0.3 mm, let's say you remember 3 French is equal to 1 mm. And this is the SPC catheter, suprapubic catheter. Malicot catheter, like I said, nobody is using these days. Okay, Malicot catheter, although I have seen, but like 10 years back, I was just seen that, okay, what is this? This is Malicot. Nobody used Malicot. Okay, there is a flower-like thing in the beginning. There is no bulb. Nobody used Malicot. Okay. Then, what are these staplers? This one is the skin stapler. Image-based question. Recently in the foreign medical graduate exams, this was asked. I'll tell you what was asked. This stapler is TA stapler. TA stapler is used to close the end or lumen of bowel. Close the end or lumen of the bowel. Angle of Veris needle, if the patient is obese, you have to go 90 degree. If the patient is thin, you have to go 45 degree towards the pelvis. Okay, 45 degree towards the pelvis for thin patients and 90 degree for obese patients. This is GIA stapler, also known as linear cutter, which is written here. Okay, it is used for side-to-side anastomosis of bowel or stomach. Side-to-side anastomosis. And the last one is circular stapler, also known as EEA stapler. EEA is the function end-to-end anastomosis. Okay, end-to-end anastomosis. Okay, so I'm sure all of you must seen how a laparoscopic surgery is done. There is one person who is showing the camera or the telescope, and then there is a surgeon who is doing the main surgery. There might be some other person who is assisting also. So when the surgeon is doing the surgery, between his two instruments, left hand and right hand, what should be the ideal angle? That is known as manipulation angle. That should be 60 degree between the two instruments of surgeon. What should be the angle between the camera and the surgeon instrument? This is azimuth angle. That should be 30 degree. 30 degree. Okay, and suppose this is the abdomen, and we are putting these instruments like this, So what should be the angle between these instruments and this horizontal line? This is elevation angle. Elevation angle. That should also be 60 degree. Angle between the instrument and the horizontal surface, elevation angle, 60 degree. Okay, so three angles: elevation angle, azimuth angle, and manipulation angle. Now, while doing laparoscopic surgery, when everybody is looking at the main organ where you are doing the surgery, suppose your instrument which is having the energy source, okay, the monopolar current comes. So that instrument touches another metallic instrument, and now the current will pass from your main thing to the other, and then it causes injury. This is known as direct coupling. Okay, there are three types of this energy source injury can occur during laparoscopic surgery. One is direct coupling. Your instrument touches another metallic thing, and that has caused injury. The current has passed through that. Okay, suppose there is this insulating coat on the instrument. Suppose that insulating coat is damaged physically and the current leaks from there and causes injury. That is insulation failure. Insulation failure. That also you can easily identify. Okay, these are image based questions. Direct coupling you will identify. Insulation failure you will identify. And if you see that picture and you are not able to identify that whether it is insulation or direct, if it is not insulation and direct, something else. Okay, the instrument is not touching anything, but somehow the current is leaking and going into the surrounding organ and causing injury, then it is capacitive coupling. Okay, capacitive coupling, the current leaks without any insulation failure, without any direct coupling. Sometimes the current leaks and goes to the surrounding thing and can cause injury. Capacitive coupling. Okay, image based question. Image based. Okay, I'm sure you know what is happening in this. This is robotic surgery. What is this? When you use a special type of port where there is one incision and through that you can put multiple ports, this is single incision laparoscopic surgery. Single incision laparoscopic surgery. Hepatobiliary pancreatic is just half an hour, 40 minutes. Okay, so don't worry. I guess by 7:30 you will get your break. You will get your break by 7:30, 7:40 max. Okay, so you have given so much the cooperation is such a good cooperation you did for almost 3 hours. I think half an hour you can sit. Okay, so this is when you go through the natural opening and do the surgery, oral cavity, anal opening, vaginal opening, natural orifice, transluminal endoscopic surgery. And same as laparoscopic surgery, but you are doing in the thorax, then it is video assisted thoracoscopic surgery. Video assisted thoracoscopic surgery. Just one thing you remember in VATS, that in laparoscopic surgery we create the space by putting carbon dioxide. In VATS we create the space by deflating that side of lung. Okay, we deflate that lung. So if you deflate the lung, you'll have enough space to do the surgery. TA stapler is to close the end. Suppose, okay, let's see. Suppose this is one bowel. This is another bowel. So first you put a GIA stapler. So it will cause anastomosis between these two. Okay, GIA stapler. So now it will appear like this and this. Okay, this anastomosis has been done. Now these ends are open, so if you put a TA stapler, it will close this end. So TA stapler is used to close the end of the bowel or lumen of the bowel. GIA is to do side-to-side anastomosis, and circular is to do end-to-end anastomosis. Video assisted thoracoscopic surgery. Video assisted thoracoscopic surgery. Okay, VATS. These are the two common energy sources. Okay, this is the monopolar diathermy and this is the bipolar diathermy. Okay, in the bipolar mode, the current does not pass through the patient body. In the monopolar, it passes through the patient's body, and that's why it cannot be used in the patients who are having pacemakers and all. There is a dispersive pad which will collect the current and then it makes a circuit. In bipolar, the circuit gets completed between the two ends of this prong. This instrument is another commonly used energy source. Harmonic scalpel, which is based on the ultrasonic energy. Ultrasonic energy, 20,000 to 50,000 to 50,000 hertz is the frequency of this harmonic scalpel. Okay, it has minimum lateral spread. The energy does not go laterally, and minimal you'll say a minimal heat production. The heat production is less than 60 degrees. Color coding of cautery, there is no color coding. First of all, cautery is not the better word, it is diathermy. That yellow color button is used for the cutting and the blue color button is used for the coagulation in the monopolar. Okay, bipolar there is no color. Okay, this is to cut and this one is to coagulate. Okay. Hepatobiliary, see 749, I guess it is 750, consider it as 750, there is 760, hardly 17 pages, okay, nothing. We have already done 50 pages, 17 is nothing. Okay, in the liver, Coinod had divided the liver into different segments. How many segments? 8 segments. So on what basis Coinod had divided the liver into 8 segments? On the basis of branching of the hepatic vein and the portal vein. So based on the branching of the hepatic vein and portal vein, these 8 segments are divided. Okay, segment on the right side there is segment 5, 6, 7, 8. On the left side segment 2, 3 and 4. Segment 1 is not on any side, it is a different segment, so it's not given on any side. Okay. Now we'll see, I hope you know the segments. Okay, in segments also, just see. Two, 3, 4, A, B, 5, 6, 7, 8. Okay, so this is the right side, this is the left side. This is the right anterior section. And this is the right posterior section. Okay, I'm talking about the sections. And this is the left lateral section and this is the left medial section. Okay, so based on what is right, what is left, what is anterior, medial, lateral sections, there is terminology of liver resection. Terminology of liver resection known as Brisbane terminology. Okay, so right hepatectomy. What are the things we'll remove? 5, 6, 7, 8 segments. Left hepatectomy. 2, 3, 4. Right anterior sectionectomy. 5 and 8. Right posterior sectionectomy. 6 and 7. Left lateral sectionectomy, 2 and 3. Left medial sectionectomy, 4. Last two are important. Right trisectionectomy, also known as extended right hepatectomy. So right hepatectomy we remove 5, 6, 7, 8. If it is extended, we will remove segment 4 also. Similarly, left trisectionectomy or extended left hepatectomy, 2, 3, 4 is left hepatectomy. Extension, one more section. So what section? The right anterior will go. So 5 and 8. So these are important MCQs. Brisbane terminology of hepatic resection. Liver carcinoma risk factor, just the most common risk factor I'll tell you, that is hepatitis B. Hepatitis B, hepatitis C, alcohol, these are the common risk factor. Clinical features, there will be pain, weight loss, jaundice. They don't ask these things. They ask which is the most common paraneoplastic feature. Paraneoplastic, you need to remember in two conditions, HCC and RCC. Most common paraneoplastic in hepatocellular carcinoma is hypoglycemia. And in renal cell carcinoma, it is increase in the ESR, erythrocyte sedimentation rate. Investigation of choice is, you can say triple phase or 4-phase CECT. Okay, 4-phase or triple phase CT is the same thing. See, 4-phase CT, how we do, the first picture will take no contrast. We don't give any contrast. No contrast. In the second, after giving IV contrast, suppose you give contrast, this picture you will take approximately 12 seconds after the contrast. So this is the arterial phase. Then you take another picture 55 to 70 seconds, that is the portal phase. And then you take one picture usually 120 seconds later, that is delayed or venous phase. So this is the meaning of 4-phase or triple phase. May they don't include non-contrast wala. Okay, so remember one important thing. Liver ka the most of the blood supply to the liver, it comes from the portal vein. But hepatocellular carcinoma has a peculiar feature that it takes blood supply only from the hepatic artery. It does not take from the portal vein. So that's why if you can see, you cannot see any tumor here. But in this arterial phase, there is enhancement. Can you see? Arterial phase enhancement, and then it gets washed out. So that is the typical picture or the typical finding: arterial phase enhancement and delayed phase washout. This is the typical, you can say, the finding you will get in the triple phase or 4-phase CT. Okay, so these all the 4 phases are shown. Not portal phase, delayed phase. Portal phase may it is becoming less and less, but complete washout you will see in the delayed phase. Okay, now there are in the hepatocellular carcinoma, these are the staging, Okuda staging. What are the things? Okay, you don't have to remember what exactly is inside. You just need to remember what are the things we see in clip staging and Okuda staging. Okay, these cancer of liver Italian program, Okuda staging, these are the parameters we see. TNM staging, nobody asks in this. Tumor marker is, yes, serum alpha fetoprotein. Alpha fetoprotein is the tumor marker. Arterial phase 12 seconds. Okay, the Nidhi. Child poo classification is an important classification. They ask first of all what are the different parameters we see, and sometimes they ask you to calculate also, and certain points are given 1, 2 and 3. Bilirubin less than 2, 2 to 3, more than 3. Albumin more than 3.5, 2.8 to 3.5, less than 2.8. Ascites no. Controlled ascites, uncontrolled ascites. Prothrombin time, better they will ask INR or prothrombin time. INR will see. less than 1.7, 1.7 to 2.3, more than 2.3. Encephalopathy same, no, controlled and uncontrolled. So the maximum points, it can be 15, the minimum is 5. Class A is when there are 5 to 6 points, class B is when there is 7 to 9 points, and class C is 10 to 15 points. Class A means like we people, we have a normal liver, so we have a normal hepatic reserve. So a major part of the liver can be removed if it has to be removed because of some cancer or something. Class B is a minor part of the liver can be removed. The liver is not exactly normal, but yes, you can remove a part of it. Class C, the liver is too bad that you cannot remove any part of the liver from that. If you remove it, then the patient will die. So for these people, the only option is you change the liver. So that's why if the CTP is more than 9, that is an indication for transplant. Okay, cirrhotic liver disease is a topic ekta of medicine. We don't treat cirrhosis. Okay, we remove liver in case if it has to be removed. Cirrhosis patient, they don't come to surgeons. Okay, that is alcoholic liver disease, they go to medicine. BCLC is Barcelona Cancer Liver Clinic. Okay, this is the most commonly used criteria or the guideline for treating the hepatocellular carcinoma. I'll tell you one thing. Hepatocellular carcinoma in one tumor, single hepatocellular carcinoma in non-cirrhotic liver means mostly CTP-A and few B. The first line treatment is resection. You remove that part of the liver. Hepatocellular carcinoma in cirrhotic liver, mostly CTP-C and few B, most of the B. Treatment is liver transplant. If you remember these two lines, you will be able to answer the question in the exam. Okay, so this is in general the treatment. So see, when you are doing, suppose this is the cancer, hepatic resection you are planning. Suppose before we plan the hepatic resection, we get a CT done, that is known as CT volumetry. So CT volumetry pay will know that how much is the liver remnant. Suppose you are removing it from here. So this is known as future liver remnant. So there has to be a minimum FLR so that the patient can survive. Otherwise you cannot leave just 2 grams of liver and you will think that it will regenerate. It will not regenerate. So what should be the minimum FLR? Okay, in non-cirrhotic liver, it should be 20 to 25%. And in cirrhotic liver, it should be 40%. It should be 40%. Okay, so suppose this is the portal vein. One very important question. Suppose you have done the CT volumetry and now your FLR is less. So now you cannot do the surgery because that part of liver is not going to support the body. So what people they do is they do the portal vein embolization on that side which you are supposed to remove. So they ask the question why portal vein embolization is done in hepatocellular carcinoma. Okay, remember the answer is it does not decrease the vascularity or the size of the tumor because hepatocellular carcinoma is taking supply from hepatic artery. But when you put the embolus, now most of the blood will go on this side and it will increase the FLR. Okay, so this portal vein embolization, and there is a new procedure ALPPS, this is done to increase the future liver remnant. ALPPS is associating liver partition and portal vein ligation for stage hepatectomy. Okay, so yes, these two are done to increase the FLR. Just remember this thing. Now, comparison between a primary hepatocellular carcinoma and a fibrolamellar variant of the hepatocellular carcinoma. Hepatocellular carcinoma is 4 to 8 times more common in males as compared to females. Fibrolamellar, it is same. Age usually 40 to 60 years. In fibrolamellar, the median age is 25 years. Tumor nature, more aggressive, it is less aggressive. Resectability is less, in this it is better. Association with cirrhosis, it is there, not there. AFP status will be high, it will be normal. Association with hepatitis B, it will be there, not in this case. Prognosis, poor, better. Okay, so this fibrolamellar cancer is an important question for the exam. Okay, so just you need to remember the differences between fibrolamellar and a classical hepatocellular carcinoma. Yes, neurotensin is a tumor marker. Portal hypertension, normal portal pressure is around 5 to 10 millimeter of mercury. Portal hypertension, it will be more than 10. Okay, so when the pressure is high, especially when it is more than 12 millimeter of mercury, there are chances of variceal bleed. There can be esophageal or gastric variceal bleed. The drug of choice for acute variceal bleed is octreotide. And once you control that acute bleed, the drug of choice for prophylaxis will be beta blocker, that is propranolol. Propranolol. Liver metastasis, if you are getting the sufficient FLR, you can remove the liver metastasis in colorectal cancers and the neuroendocrine tumors of the pancreas. Endoscopic management, when you do the treatment of the acute variceal bleed, endoscopic variceal ligation, that is, you will put a band, which is shown here. Endoscopic variceal ligation or band ligation is the endoscopic management of choice. Otherwise, if endoscopy is not available, you can put a special type of tube to put pressure to give balloon tamponade. The name of the tube is Sengstaken Blackmore tube. That is just a temporary way to give pressure and hold the bleeding. Tips is transjugular intrahepatic portosystemic shunt. You do a shunt between the portal system branch and the systemic system branch, that is hepatic vein, a radiological intervention, and very frequently done these days. Portosystemic shunt, just remember one name. What is the example of selective shunt? Although these days open shunt surgeries are very rarely done, if they ask anything, they will ask which of these shunt is selective. So selective shunt, just one example, distal splenorenal shunt. That is selective shunt, rest other shunts are non-selective. And if all these methods they fail to control the bleeding and the patient is about to die, as the last resort, you can do the devascularization procedure, Sugiura surgery. You will do devascularization of the distal esophagus and the proximal stomach, Sugiura surgery. So these are the different ways by which you can stop the bleeding in a case of acute variceal bleed. Yes, Warren shunt is another name for distal splenorenal shunt, but in the exam usually they will write distal splenorenal, they will not write Warren shunt. Okay. Tips is between a branch of the portal vein and hepatic vein inside the liver. Okay, Shreya, portal vein and hepatic vein inside the liver. Now, liver infection, pyogenic and amoebic liver abscess. E. coli is for pyogenic and Entamoeba histolytica is for amoebic liver abscess. Pyogenic liver abscess is usually seen in elderly patient. Amoebic is seen in young immunocompetent patient. Clinical features, pain and fever will be seen in both. In pyogenic, jaundice is seen. In amoebic, there will be history of diarrhea. Jaundice is not seen in amoebic liver abscess mostly. Most common LFT abnormality, increase in the alkaline phosphatase, and here increase in the PT and INR. Treatment option, drainage is required in almost all the cases of pyogenic liver abscess. Amoebic liver abscess, metronidazole is the treatment. In few cases, the drainage can also be done. And amoebic liver abscess, very typically This is the appearance, I'm sure all of you know, anchovy-sauce pus. Anchovy-sauce pus is seen. Okay, on ultrasound, the liver abscess will appear hypoechoic. And in the CT, you will see there is rim enhancement. The CT scan, the peripheral rim enhancement. Central part, so you will see hypodense, but peripherally there is rim enhancement is seen. Okay. Another infection which is more commonly asked as the image-based question is this. You can see the CT, you can see the ultrasound. Without any further hint, you can tell that this is a high ducted disease of liver. The cause is echinococcus. The drug of choice is albendazole. Treatment option, you can go for surgery or you can go for, these days the more commonly option is you will do puncture, aspiration, injection of scolicidal agent and re-aspiration. Okay, pair. Benign liver lesions, there are 3 lesions. Hemangioma, which is the most common. Okay, it is a vascular lesion, and in hemangioma usually you will see this. This is the, okay, sorry, I have written there. This is the image. You'll see the early peripheral enhancement with centripetal filling, and on MRI it will appear very hyper intense. Then another tumor which will have a central scar appearance is known as focal nodular hyperplasia. Central scar, focal nodular hyperplasia. Yes, light bulb sign. Drug of choice was albendazole in hydrated. So these are the first most common tumor is this. Second most common is FNH, and the third common tumor is hepatic adenoma. Now, hepatic adenoma is, MCQ wise, it is more important. The important, you can say, the risk factor. The one thing which you should remember in the risk factor is OCPs, oral contraceptive. Complication, the one thing which you should remember is increased risk of cancer. It can turn into hepatocellular carcinoma. There are different types, subtypes, beta-catenin, HNF1-alpha, and inflammatory. One word about these things. Beta-catenin, maximum risk of cancer. HNF, minimum risk of cancer. Sorry for this small font, sorry for the decreased space in this. And inflammatory is the most common type. So maximum chance of turning into a malignancy, beta-catenin mutated. Minimum chance is HNF1-alpha, and inflammatory is the most common type of hepatic adenoma. Yes, increased risk of bleeding, increased risk of rupture is there in hepatic adenoma. Choledochal cyst is congenital dilatation of the biliary tree that includes extra as well as intrahepatic. Okay, type 1, where there is fusiform dilatation, is the most common. Type 2, when there is dilatation from saccular dilatation, this is the least common. Type 3, there is dilatation of the terminal part. Type 4A, both extra as well as intrahepatic. Type 4B, multiple dilatation of extrahepatic only. And type 5, multiple dilatation of intrahepatic only. And so if I ask you which type of choledochal cyst can give appearance like 2 gallbladders, 2 gallbladder appearance. First two, both the pics were of hemangioma. One was CT, one was MRI. Which type can give appearance of 2 gallbladders? Case type 5 is known as Caroli's. Yes, type 2. Type 2 can give appearance like double gallbladder, 1 and 1 swelling. Okay, this was asked in the this year MCH exam. Which type of choledochal cyst can give double gallbladder appearance? That is Obviously it is type 2. Okay, like all of you have said correctly. Okay, clinical feature, lump, pain and jaundice. MRCP is the investigation of choice. These are the MRCP images of different types. Type 5, in which there are multiple dilatation, that is known as Caroli's disease. Okay, this is Caroli's. Management in type 1, 2 and 4B will do excision of the cyst followed by Roux-en-Y hepaticojejunostomy. In type 3, usually just cyst removal is good enough. And in type 4A and 5, where there is involvement of the intrahepatic cyst, liver transplant. Janvi, okay. This is, I also wanted to make clear this thing, that where is ERCP investigation of choice? Remember this thing, ERCP is investigation of choice for nothing. Nothing means nothing. Okay, ERCP is an invasive procedure. There are significant complications associated with it, like pancreatitis, perforation. So ERCP, although people they say it is both diagnostic and therapeutic, but in today's era it is mainly a diagnostic modality. It will not be investigation of choice for anything. Anything. Okay. This is just showing hepaticojejunostomy. Extrahepatic biliary atresia. Type 1 is when the atresia is limited to the common bile duct only. 2 is when it is limited to common hepatic duct. And 3 is when it involves right and left hepatic duct also. Type 3 is the most common type of extrahepatic biliary. Investigation for bile leak, yes, MRCP. Roux-en-Y hepaticojejunostomy is this. Okay, that's why I put this picture. Roux-en-Y hepaticojejunostomy is this surgery. This is the normal orientation. This is Roux-en-Y hepaticojejunostomy. You can see it later. Type 5 treatment is liver transplant. I had written there. Liver transplant. Type 4 and 5, where there is multiple cyst, liver transplant. Clinical features, there is obstructive jaundice since birth or at the time of birth rather in biliary atresia. Extrahepatic biliary atresia, this kind of surgery you can do. This is known as portoenterostomy, also known as Kasai's surgery. And intrahepatic biliary atresia, liver transplant. Okay. Intrahepatic biliary atresia, liver transplant. CBD stone investigation of choice, MRCP. Okay, Rishabh. Okay, cholelithiasis, there are 3 types: cholesterol stone, pigmented and mixed. Mixed is overall most common. Pigmented is most common in the Asia as well as in India, and cholesterol is in Western countries, it is more common. No, type 1 is not most, type 3 is most common. 90% of the biliary atresia are type 3 only. Break, yes, I'll give you the break. The moment we'll finish maybe 10 more pages. Yes, 10 more pages, it's a break and break only. Investigation, ultrasound is the investigation of choice of gallstone. You can see the hyperechoic stone, but this is the main thing which will tell you the diagnosis: posterior acoustic shadow. Okay, so if this is seen, it is a stone. If you don't see this, just this thing, no posterior acoustic shadow, it is a polyp. And if the wall is thickened, then it is acute cholecystitis. Thickened wall, acute cholecystitis. Clinical feature, there will be pain, tenderness and fever will be seen. Tenderness, you can have Murphy's sign or Bova's sign. Investigation of choice is ultrasound. But if they ask best or most sensitive investigation, then it is HIDA scan. Treatment of acute cholecystitis, it depends on if the patient comes in the within 72 hours of the onset of pain, then the treatment is surgery. If patient comes after 72 hours, then you can go for conservative treatment, and maybe 6 to 8 weeks later you can go for surgery. Okay, surgery means lap-chole only, laparoscopic cholecystectomy only. Okay. What is this condition? Next condition, there are multiple yellow flakes inside the mucosa. This is cholesterosis or strawberry gallbladder. On ultrasound, if you see this comet tail appearance, okay, I'll show you comet tail appearance, then it is mainly seen in adenomyomatosis. And this is not a disease, it is a congenital, you can say the variation known as Phrygian cap. Phrygian cap, just a congenital variation. Okay, laparoscopic cholecystectomy, these are basic steps. You just need to remember one thing, that there should be only 2 structures in the Callet's triangle before you cut and divide. That is known as critical view of safety. Okay, you should see only 2 structures in order to avoid the bile duct injury. Otherwise, bile duct injury is not uncommon in laparoscopic cholecystectomy, and there is a classification for that. That is Strasberg classification. Strasberg classification. Class A is when there is bile leak from cystic duct stump. Bile leak from the cystic duct stump. Class B is there was an aberrant duct which the surgeon could not identify and he ligated. Ligation of aberrant sectoral duct. Class C में there was injury from the aberrant duct and now the bile is leaking. Okay, bile leak from aberrant sectoral duct. Boundaries of Callet's is inferior surface of the liver, common hepatic duct and cystic duct. Partial transaction of CHD or CBD is class D, and class E is complete transaction. Callet's triangle का content is cystic artery. Okay, Rishabh, it is the content. If somebody is saying something else, believe me, what I am saying is correct, at least in this matter. I am very sure the boundaries of Callet's triangle. Some people they say that this is actually hepatocystic triangle and Callet's triangle is that cystic artery. That is not correct. These are the boundaries of Callet's and cystic artery is the content. Now for the stricture formation, there is a classification which is known as bismuth. So both bismuth, it is already written here, so I will not write. Both bismuth and Strasberg are very important classifications related to the biliary tree. C and D difference. C में there is injury to the aberrant duct. Aberrant duct is C. This is right hepatic, left hepatic, common hepatic duct. Sometimes there is a additional duct which is coming from here. So that is the aberrant duct, aberrant sectoral duct. Okay, it is not seen in all the patients. So if the surgeon fails to identify this and ligated it, then it is B injury. If there is bile leak coming from it, it is C injury. If the bile is coming from the main duct like this is D injury. If there is complete transaction, that is E injury. We don't have to remove that aberrant because this aberrant might be the biliary drainage of segment 6 and 7. There are chances that this segment 6 and 7, instead of draining into the right hepatic duct, that is draining into the directly into the CHD via this aberrant duct. So aberrant duct needs to be saved, identified and preserved. If you do the injury, if you ligate it, then also it is a bad thing. If you cut it, then obviously it is a bad thing. Calyx, I'll write. See, inferior surface of liver. Write inferior liver. Common hepatic duct. Cystic duct. This is calyx. And this is the content. I'll not write cystic artery, just think that this is cystic artery is the content. And vascular injury classification, don't worry, the name is Hanover classification. That was actually inicet question. Inicet have this tendency of asking something, aberrant. So that was the Hanover classification. In this we'll see the bile as well as vascular injury. Don't worry, they will not ask what is Hanover classification, the details, just the name Hanover classification. Okay, this is just how many pages? Okay, 5, 6, maybe 7 pages. Management of bile duct injury. See why you are feeling that it is too much, because see, medicine surgery is almost same type of question. Medicine, 5 faculties they taught you medicine. And surgery just 3. So obviously somebody will have a bigger portion. So don't think, consider like 3 faculties are teaching you these topics. So now it will not appear too much. Okay, bile duct injury, if it is detected intraoperatively and the injury is less than 50% of the circumference, then you'll do the primary repair with T-tube. And if it is more than 50%, then you have to remove this segment, resect. And after resection, if the gap between this is less than 1 centimeter, then you can do end-to-end anastomosis. More than 1 centimeter, hepaticojejunostomy. Now, in case of ligation of aberrant duct, Raval, there is no bile leak. Okay, in type B, there is no bile leak, but you will still call it as injury because you are not supposed to ligate it. Okay, in type B, there is no bile leak. Post-operative period, this is what they ask in the question, like 3 days after the laparoscopic cholecystectomy, patient comes back with pain and tenderness and fever. What you are supposed to do? 3 things. Drain the bile collection. Second thing, do the MRCP. And third thing, delayed repair. That is hepaticojejunostomy, usually 8 to 12 weeks later. 8 to 12 weeks later. Okay. Okay, so this is bile duct injury. In this case, just tell me what is this condition? What is the name of this condition? This was also asked in the in this super specialty exam. When there is a stone impacted in the Hartmann's pouch or in the cystic duct, which is compressing the CBD or CHD, causing obstructive jaundice. Yes, I know you know Mirizi syndrome. These are the different types of Mirizi syndrome. If you can remember, it is fine. You should remember actually, but at least you should know what is Mirizi syndrome. All of you are saying correctly. Very nice, very good. Mirizi syndrome. What is this condition in which the X-ray shows some calcified globular structure in the right hypochondrium? The CT shows a very nice calcification all around the wall of the gallbladder, porcelain gallbladder. And porcelain gallbladder there is increased chances of turning into malignancy, so that's why we remove it. What is this condition in which the stone from the gallbladder has come into the intestine by cholecystoenteric fistula, and now these stones in the terminal part of ileum goes and causes obstruction. Okay, so this is gallstone ileus. Triad in the gallstone ileus is known as Wigler's triad. Okay, you will see in this stone in the GIT, in the bowel, there is dilated bowel loops and there is pneumobilia. Pneumobilia means bile in the biliary tree. Okay, remember one very important question, very important. Sometimes when the stone comes and causes gastric outlet obstruction, then that condition is known as Bouveret syndrome. Okay, very potential question in this year exam. What is Bouveret syndrome? Gallstone causing gastric outlet obstruction is Bouveret syndrome. Okay, in the treatment, when the patient comes with gallstone ileus, the first thing is you do the surgery and remove the obstruction. Later on in the second stage, you will go ahead and do the surgery for the gallbladder and the intestine. Okay. Gallbladder cancer risk factors already written. Just two important things. Gallstones more than 2.5 centimeter. Gallbladder polyp more than 1 centimeter. Most common site for gallbladder cancer, fundus of the gallbladder. Management, limited to mucosa. Limited to mucosa. I'll drink water, just 10 minutes, maybe 10 minutes, and then it is done. Limited to mucosa is simple cholecystectomy. If it goes beyond mucosa, radical or extended cholecystectomy, in which we remove the lymph nodes and a part of the liver also. Okay, so just this much. You don't have to remember the whole TNM classification for it. Choledocholithiasis clinical features: obstructive jaundice, and investigation of choice MRCP. Management, either ERCP and stone removal, or you can do surgery. So once you do surgery, during surgery you put a T-tube, and after 10 days you do this T-tube cholangiogram. Okay, so this is T-tube cholangiogram. Beyond mucosa means if it involves the muscular layer, if it is involving serosa, that is the meaning of beyond mucosa. It goes deep to mucosa. Cholangiocarcinoma, just one thing, that the most common site is perihilar. That is known as Klatskin tumor. Perihilar cholangiocarcinoma is the most common site. There is something known as Bismuth-Corlett classification for this cholangiocarcinoma. Type 1 is if it is involving only the common hepatic duct. Type 2, it has reached up to the hilum. Type 3A. ERCP in acute cholecystitis. What will you achieve in ERCP in acute cholecystitis? Okay, there is no role. 3A, if it goes into the right-sided secondary biliary radical. 3B, if it goes into the left-sided secondary biliary radical. And 4 is if it goes bilateral secondary biliary radical. Pancreas, let's see, the annular pancreas is because of the abnormal rotation of ventral pancreatic bud. Klatskin is just the perihilar cholangiocarcinoma. The cancer is present at the bifurcation, or you can say from the secondary biliary radical up to the common hepatic duct. Any cancer comes under Klatskin tumor. That is perihilar, around the hilum region if there is cholangiocarcinoma. Okay, so there is a part of the pancreas which is around the second part of the duodenum. Remember, the child will have usually non-bilious vomiting. X-ray can give a double bubble sign, and treatment is, I'm sure you know that you are not supposed to cut the ring. All you have to do is just do a duodenostomy. Pancreas divisum is during the development. This is also a congenital condition. The ducts of ventral pancreatic bud and dorsal pancreatic bud, they fail to fuse. Non-bilious, yes, because see, the bile duct opens into the second part. This obstruction is proximal to the opening of the bile duct. So that's why the bile usually does not go in the vomitus. Ducts of ventral pancreatic bud and dorsal pancreatic bud fails to fuse. Pancreas divisum, there is risk of acute pancreatitis. Strasburg type E is when there is complete transection of the bile duct. Complete transection, that is Strasburg type E. So acute pancreatitis, if I ask you what is the most common cause? Most common cause is gallstones. Okay, now these are the signs of hemorrhagic type of pancreatitis. If this ecchymosis is seen in the flank area, this is Gray-Turner sign. Gray-Turner sign. This is Cullen's sign around the umbilicus, and in the groin it is Fox sign. Yes, chronic alcohol, very good. Now see, severity of the pancreatitis is these days if there is persistent organ failure for more than 48 hours. Okay, so this is the most important severity criteria, modified or revised Atlanta criteria. Organ failure for more than 48 hours. Otherwise, there are other severity criteria also. These are the criteria I have written. In this, the most important one, if you want to remember, it is CRP, because this was asked in the exam. CRP more than 150 is also severe acute pancreatitis. There are lots of criteria to say severity, but we follow usually revised Atlanta, and this can be a question, CRP more than 150. Investigation of choice is CECT for acute pancreatitis. You can see sometimes the pancreatic collection gets enclosed by a fibrous layer or a inflammatory granulation layer, and that is known as pseudocyst. Okay, because there is no true epithelial or endothelial lining, that's why we call it as pseudocyst. Remember one thing about pseudocyst, that the most common cause of pseudocyst is chronic pancreatitis followed by acute pancreatitis. Okay, so don't do this mistake in the exam. If they ask what is the most common cause of pseudocyst, it is chronic pancreatitis. On the X-ray, if you see the calcification in the pancreas, on the CT, if you see the calcification in the pancreatic parenchyma, or on MRCP, if you see a stone in the pancreatic duct, then this condition is chronic pancreatitis. The moment any calcification comes in the pancreas, with confidence you can say chronic pancreatitis. Pseudocyst, when patient gets shifted from medicine to surgery, pseudocyst is, the medicine people, they never take pseudocyst. Okay, they always try to shift all these pancreas cases to the surgery. We take the patient, okay, instead of arguing with the medicine people, we take we managed pancreatitis better than, I mean, no offense, better than medicine people, so we take the patient. So chronic pancreatitis, what are the surgeries done? Yes, chain of flakes appearance can be seen on MRCP. This surgery, tell me the name. Tell me the name of these surgeries. These two are the drainage procedures. Okay. This surgery is Pistos surgery. Okay. Also known as longitudinal pancreaticojejunostomy. This is Duval surgery. These two are the resectional procedure. In this we resect the head of the pancreas. This is Baker surgery and this is Fraisse surgery. Yes, very good. Glad to see that you remember the names of these chronic pancreatitis surgeries. Carcinoma, head of pancreas. This image, exactly this image was asked in the exam, and they asked, what is this surgery? Then identify the procedure. This is Whipple surgery, also known as pancreaticojejunostomy. Pancreaticoduodenectomy. Pancreaticoduodenectomy. So after doing this, we do 3 anastomosis. The order is, first we do PJ, then we do hepaticojejunostomy, and third we'll do is gastrojejunostomy. So this is the order of anastomosis after doing that. Indication, periampullary cancer. That includes carcinoma, head of pancreas also. Most common complication after Whipple's is delayed gastric emptying. Delayed gastric emptying. Okay, this is the last page. No, second last. Okay, fine, last, second last is the same thing. Cystic neoplasm of the pancreas. See, there are 4 cystic lesions of pancreas. One is pseudocyst, that is a benign lesion, and there are 3 cystic neoplasm: mucinous, serous, and IPMN. IPMN is intraductal papillary serous, intraductal papillary mucinous neoplasm. Sometimes there is confusion in these, to differentiate whether it is pseudocyst or a cystic neoplasm. If you check the fluid analysis in pseudocyst, there is increased amylase and decreased CEA. CEA is carcinoembryonic antigen. In mucinous, ulta will be seen, increased CEA and decreased amylase. In serous, both will be low, decreased CEA and decreased amylase. And in IPMN, both are high, increased CEA and increased amylase. Serous cystic neoplasms are usually benign. Mucinous and IPMN, they can be malignant. Okay, now this is in case of IPMN, this is recently a question was asked. There is something known as Ohashi triad. Ohashi triad is dilated main pancreatic duct, mucin discharge from the ampulla, and fish mouth appearance of the ampulla. Normal level, no need to remember the normal level. No need to remember the normal levels. Okay, so this is Ohashi triad seen in IPMN. This could be a potential question. Till now they have not asked, but this could be a potential question. Neuroendocrine tumor of pancreas, most common cancer is non-functional. Most common cancer associated with Men's syndrome, that also non-functional. So if they ask most common functional tumor overall and with Men's syndrome, then overall the most common functional tumor is insulinoma, and associated with men, gastrinoma. Okay, so the problem with the neuroendocrine tumor is how to localize. Okay, so initial investigation is you go for CT and MRI. If it is able to localize, nothing else. Otherwise, you can go for a nuclear scan like somatostatin receptor scintigraphy or dotatate scan, or you can go for endoscopic ultrasound, and in the end, intraop ultrasound. So this is overall the best investigation. Endoscopic is best pre-op investigation to localize pancreatic neuroendocrine tumor. Okay, so with this we finish this extensive session. I apologize for not giving you break. Sometimes we need to stretch a bit, and I know it is difficult for you. You are studying since morning, but my best wishes to all of you. I can see your chat. You have read the things. You have understood the thing. I am very sure, very hopeful that you will get very good marks and you will get very good rank. Hope to see you soon as a surgeon. I mean, if you want to take surgery. Okay, so thank you very much, and God bless you all. I'm sure you will do very well. Now we'll meet again in some form, maybe in some conferences of surgery, somewhere else. Okay, so thank you very much, and God bless you all. Good night.